Okay. So again, with chapter 19, we're just going to go into the details or differences between heart failure, in particular left and right-sided heart failure. Dysrhythmias, you guys will cover that when you get into med-surg, okay? And this is why we have to tear this down for the sake of time. Okay, so when we talk about heart failure is the inability, okay, of the heart to maintain sufficient cardiac output to meet metabolic demands. And we probably touched on this a little bit, especially when we talked about a patient having an MI. So we went over the different types of MI and what's happening when there's a lack of blood flow getting to the heart muscle tissue, okay, so oxygenated blood flow. So at any point where the heart is not getting enough oxygenated blood flow to meet the metabolic demand of what that heart needs to do, that is considered to be heart failure, okay, or that patient is in a state of heart failure. So this can results in congestion of blood flow, in systemic or pulmonary venous circulation. Please make sure you understand that part because this is where the right-sided and the left-sided comes from, okay? So depending on what type of heart failure this person is undergoing, it is a possibility that they can have definitely congestion of blood in either the right side or the left-sided circulation, okay? Now, this will also cause the inability to increase cardiac output to meet metabolic demands. And I think we already know that the body will try to compensate for that. So even when cardiac output is low, which we talked about last week or the week prior, when cardiac output is low, please understand that the body will always try its best to bring it up, okay, with sympathetic nervous system. But in this situation, it will drop. Now, the increase in incidence, they say this is the most common reason for hospitalization. Definitely older age, so over 65 years of age, okay, is more common. However, I think we all know that heart failure can happen in anyone, okay, so at any age. Now, the etiology and pathogenesis. So heart failure is a potential consequence of most cardiac disorders, okay, so keep in mind that an MI, any type of valvular issue like mitral valve prolapse or even infective endocarditis, so whatever it may be, could possibly lead a person into heart failure. And we actually seen this term a lot when we talked about the valvular disorders, okay, that it can lead to left-sided and right-sided heart failure. So the most common cause is myocardial ischemia, which is followed by hypertension and dilated cardiomyopathy. Please make sure you, highlight that second sentence. That is important to know because usually what are the most common causes of heart failure is usually some sort of underlying cardiovascular issue, okay? And most of the times they do believe hypertension or something along that line. So this results from an impaired ability of myocardial fibers to contract, relax, or both. So when the heart is not getting enough blood, obviously it's not going to be able to contract or relax or do whatever the function needs to be done, which means it's not going to move, therefore leading into a backup of blood, okay, into whichever side is being affected. So, the next slide that you guys have is this. So this is a very nice diagram, I think, for you guys that are visual learners to just kind of understand the pathogenesis as to what's happening when a person has heart failure and actually understanding also the cardiac output and how the body responds to when the person is undergoing heart failure. So heart failure will lead to baroreceptor response in the brain. Okay, that activity will get activated and tell the sympathetic nervous system, hey, the body is undergoing some sort of heart failure, which means obviously cardiac output is dropping. So what is it going to do? The sympathetic nervous system is going to try to increase the heart rate, get the blood pumping so it can stop that situation. So this can therefore increase cardiac output. Okay, so this is a compensation. Another part of the compensation that occurs is when we have our RAS activation that decreases glomerular filtration rate. And I think we all know that if we decrease glomerular filtration rate, this will cause fluid retention, increase the preload. Now, if you increase fluid retention and increase the preload, that means that now we're going to have more blood. Okay, so now we're going to have more blood that's able to circulate, therefore increasing cardiac output. Then the last thing here is increasing ventricular wall tension. Okay, and they have here myocyte growth. And so basically this is just talking about the contraction of the ventricles. Okay, so the contraction of the ventricles, able to contract, making, or I should say leading into a hypertrophy. Not a hypertrophy in, I don't want to say a negative sense, or let's say a pathological sense, but hypertrophy in a physiological sense. We want hypertrophy so we can actually have a lot of force to push the blood out, okay, so we can increase cardiac output. Okay, so does this all make sense? So this is all compensation, okay, what your body does when it's undergoing heart failure. Okay, now let's get to the good stuff. Okay, so the first heart failure we want to talk about is what is called left-sided heart failure. Okay, now the important thing here is that when we talk about left and right-sided heart failure, the big picture here is that you need to know and understand what is happening where the body, I should say, what is happening when there's a backup of blood leading into certain signs and symptoms within a patient. Okay, so most often associated with backward effects, and then we have forward effects. Now, I should probably draw a heart on this one, so we can understand what's going on from the back and to the front. Okay. So when a person has left-sided heart failure, okay, so the left side is failing, the backward effects will result in an accumulation of blood in the pulmonary circulation. Okay, so hopefully that makes sense. If the left side is failing, a backward effect, or let's say a backward issue that's going to occur, is where it's coming from. So which means that this will lead into pulmonary congestion. Okay, so remember, pulmonary veins dump into the left atrium. So what's going to happen is there's going to be a backup of blood in the pulmonary circuit. Okay, so that's the backward effect. So it can lead to accumulation of blood in the pulmonary circuit, pulmonary congestion, and also edema. So that's a backward effect. When we have a forward effect, so what would be a forward effect if the left side of the heart is not working? Keep in mind the left side of the heart is supposed to supply blood to everywhere in the body, with the exception of the lungs. So therefore, this will lead into diminished delivery of oxygen and nutrients to tissues and organs. Okay, so now, if the left side is not working, it's not going to be able to deliver all the blood to the tissues and organs. Okay, and that's a forward effect, because that's what it's supposed to be doing going forward. Does that make sense? Okay. So, this is a diagram here. And I left some of these diagrams within the PowerPoint for those of you who like flow charts. Okay, some people can do without them, but some people do like flow charts. And so this basically goes over in a little more detail because it's adding an ejection fraction and preload and afterload and things like that. But it just goes over the same thing that we just talked about. Okay, so that's that. Now, these are the signs and symptoms. Okay, so this is something I do want you to put a check mark by, and I do need you to know the signs and symptoms of a backward effect and forward effects with a person with left-sided heart failure. So, when we talk about backward effects, we already stated earlier that a backward effect is going to lead to some sort of blockage or in the pulmonary system or pulmonary congestion. Okay, which means what types of signs and symptoms would you expect this patient to have? Something related to pulmonary issues, obviously, okay, because there's a pulmonary backup. So they would have dyspnea on exertion. Orthopnea is difficulty breathing while lying down. Orthopnea is a clinical term for difficulty breathing while lying down. Cough, okay, from pulmonary for the lungs. Paroxysmal nocturnal dyspnea. Okay, so paroxysmal, if I can remember, I think that term is like kind of intermittent, is another term for intermittent. Nocturnal is at night. Dyspnea, difficulty in breathing. Okay, so they will have difficulty in breathing at night. Cyanosis. okay, and basilar crackles, which means that when you hear and auscultate your patient's lungs and you tell them to breathe in and out, when they breathe in and out, you really should not hear anything, but if you do hear crackles in your stethoscope, that means that that patient has fluid in the lungs. So at any time crackles represents fluid buildup in the lungs. Okay. Which is part of that whole edema situation. Okay. So, and that makes sense. Okay. Now, forward effects, again, keep in mind, forward effects is the fact that the left side of the heart is not able to supply blood, okay, to the rest of the body. So what's going to happen, these patients will have issues that have to do with them not getting enough blood, oxygenated blood to tissues and organs. So fatigue. Okay, so if you, let's just say, I don't want to equate it to an anemia, but let's just say if you're not getting enough, obviously, blood supply, you will feel fatigue. Oliguria is an increase in urine output. Increase in urine output. That has to do with an issue with the kidneys. So there's going to be an issue with blood supply to the kidneys. Increase in heart rate. Okay, why is the heart rate increasing? Because it's compensating. Okay, it needs to compensate. Faint pulses. So the pulses will not be as prominent or pronounced when you palpate and feel the pulse. Why? Because circulation is off. They're not getting enough blood. So they're going to have very faint pulses. Restlessness, confusion, and anxiety. Again, because of the lack of blood flow and also getting to the brain. Okay. So those are the signs and symptoms of forward effects. And again, that all makes sense because of the lack of blood flow getting to the rest of the body. Okay. Everybody's okay with that? Now, right-sided heart failure. Right-sided heart failure, they do say most common types of right-sided heart failure comes from pulmonary conditions. However, right-sided heart failure can also come from patients that do have valvular disorders and just other cardiac issues, but most commonly, usually from a patient maybe having, let's say, a chronic bronchitis or an emphysema or something like that, leading into a right-sided heart failure. So most of the times they do believe that respiratory conditions are usually the most common cause. Okay. So pulmonary disorders will increase pulmonary vascular resistance, giving a high afterload, and right ventricular hypertrophy, and they have here something called pulmonary, which is you can say right ventricular failure or right-sided heart failure. So let me give you the definition of call pulmonary. And if I'm not mistaken, I believe you guys have to chart it this way. So call pulmonary is a term for right-sided heart failure due to some primary condition. Okay, or I should say, due to some sort of cardiac condition or pre-existing condition. Let's put it that way. Yes. Call pulmonary is right-sided heart failure due to some sort of pre-existing condition. And whether that is a respiratory condition or a cardiac condition, okay, that's how you would call it call pulmonary. Now, if someone just has right-sided heart failure because maybe a valvular issue or something else is going with that particular side of the heart, you don't use call pulmonary in that term, but call pulmonary is the secondary to something else. So, the backward effects are due to congestion in systemic venous system. Please make sure you highlight that, because if we're having a backward effect on the right side of the heart, where is it backing up to? What vessel? Very good, the superior vena cava. So understand that when we have a right-sided heart failure and a backward effect, it's going to back up into the vena cava. Okay, and then there's particular signs and symptoms from that. A forward effect, believe it or not, has to do with the fact that the right-sided blood is obviously not getting to the lungs, which in turn is going to decrease the flow getting to the left side. So the forward effect of a right-sided heart failure is the left side, because the blood is not getting to the left side of the heart. Okay, so Here's another diagram. Again, for those of you who like diagrams, you can use it, it's there. So that's that. Now, look at this picture. This woman looks totally different than the other one. And in the other picture, the woman was a little smaller. This woman is larger. Okay, and I'll tell you why she's larger. So the backward affecting half here is a hepatomegaly. So keep in mind that we're talking about now venous congestion that's occurring with the backward affecting right-sided heart failure. So if we have venous congestion, it's actually going to attack organs that are supposed to be there to help clear out and, clear out, but detoxify and just help kind of filter the blood. So hepatomegaly, ascites, splenomegaly, anorexia, subcutaneous edema, which is why she looks that way. These patients will have a considerable amount of tissue edema, okay, so which is why they look larger, just because of the fluid that's building up. One thing you should always know is that when a person has edema, a lot of tissue edema, that's usually due to venous congestion, okay, venous congestion. When there's a congestion in an artery, that's usually ischemia. Okay, so it's two different things. And let me write that on the board because that is key to understand. Venous congestion leads to edema, whereas arterial congestion leads to ischemia. Okay, and so if you just jot that down, and once you understand that, that'll make sense to you. Okay, because if you have a patient that has some sort of congestion or blockage somewhere, if it's a vein or an artery, then you'll be able to understand the signs and symptoms, okay, of what's going on. So a lot of tissue edema must be the venous system, okay. Ischemia, if there's a lack of blood flow, organs are not getting, tissues are not getting enough blood supply, like maybe cyanosis, things like that, that's probably due to an arterial congestion. Okay, so two different things. Okay, oh, and jugular vein distension. Okay, so that can also happen again because the veins are congested. Now, forward effects, as you can see, are actually the very same thing as the left-sided heart failure. Okay, and I know it probably looks strange. Okay, well, why is it the same? Well, the reason why it's the same is because what the right side of the heart needs to do is get to the left. Okay, so it's actually going to be the same signs and symptoms. So for studying purposes, it'd be easier if you guys memorize the backward effects for both right and left, and the forward effects are actually the same for both right and left. Okay, but if you ever get stuck on a question and you're not understanding, okay, well, what type of, sign or symptom they're going to have, or where's the congestion, where's it backing up, don't hesitate to draw the heart out. Okay, so if you have, when you take your midterm next week, you will have paper that's given to you. Draw out the heart, draw out diagrams, do whatever it is you need to do to get to their answer. Yes?
So is this one for left-sided heart failure?
This one is for right-sided heart failure.
Right-sided.
Yeah, this one is for right-sided heart failure. And you'll know right-sided heart failure because of the edema. The edema is kind of like the clue. Okay. So they do have a lot of tissue edema because of the venous congestion. Left-sided heart failure doesn't have venous congestion. It's the right side. Okay. We got two more. Okay. So believe it or not, sometimes patients can have both right and left-sided heart failures. Okay, I know that sounds very crazy and strange, but that is possible. They can have biventricular heart failure. Okay, most often result of primary left-sided heart failure, then progressing to the right. So just make sure you know that it's usually the left side and then it progresses to the right. This will definitely reduce cardiac output, pulmonary congestion due to the left-sided heart failure, and systemic venous congestion due to the right-sided heart failure. So these patients obviously will have signs and symptoms of both. Okay, got that right. And then the very last thing here is how do you kind of diagnose this? And I'm not sure if they use this mnemonic in nursing exactly, but they do have it here, FACES, fatigue, activity, limitation, congestion, edema, and shortness of breath. So when you look at this mnemonic, what happens here, this actually combines mainly a lot of the forward effects, but it does combine some of the backward effects too. Okay, so those are the things that you would be looking for to diagnose and say, okay, well, this person definitely has signs and symptoms of heart failure. Diagnostic tests, X-ray. What do you think you would see on an X-ray if they were just to take a chest X-ray?
Cardiomegaly.
Very good. Cardiomegaly. Understand that when a chest X-ray is performed, the heart is supposed to be in a certain area or certain boundaries. If it is outside of those boundaries and the heart is much larger, that will tell you that something is definitely going on, that there's some sort of heart failure, some sort of blood backup somewhere. Okay. And then also a very good test obviously would be an echocardiogram. An echocardiogram, having an actual ultrasound of the heart, will give you an exact visual as to how that heart is contracting, if blood is coming out, if it's not, if there's a regurgitation, if there's a stenosis, all of that. Okay, and so they do look at the B-type natriuretic peptide levels, which helps make the heart contract, and the severity of symptoms are used to identify the classes or stages. And this has to be, keep in mind, monitored. Okay, so it's not just like a one-time thing and okay, that's it, we're done. Even after treatment, they still have to monitor and make sure that it is still back to the cardiac output and everything it should be. And I think that was the last. Is that the last? Okay. Okay, so that's it for 19. 19 is really quick. Let's get started with shock. Now, shock is a little more detailed. However, there are a few types of shock that I'm really going to focus more on than others, and I'll tell you those when we get to them. And I'll tell you now. Septic shock I'm going to focus on in detail, anaphylactic shock, and hypovolemic shock. Okay, I can tell you for sure I'm going to test you at least on those three. Maybe the others, but definitely those three you will be tested on. Okay. So, what is shock? Okay. Please understand that shock is a life-threatening condition. Okay, and it is still considered a cardiovascular condition. Okay, it doesn't fall under any other category but that. The issue is this with shock. You know how we talked about a lack of blood supply, okay, getting to tissues and ischemia and all things like that, okay, that can happen in any other cardiovascular condition. With shock, that same exact process occurs. However, this is where we have enough or lack of tissue, oxygenated blood getting to the tissues to the point that the tissues and the organs die. That's why it's a life-threatening condition, okay? And so we'll get into all the different types. So it is what is called a hypoperfusion, and we talked about this term the last time we met. Hypoperfusion, meaning that this is a lack of blood flow, or the rate of blood flow is actually slowed down to the point that it impairs cellular oxygen utilization, which means that the cells and tissues are not getting the oxygenated blood that it needs, so much to the point that the tissue or organ will die. Once you have a tissue or organ dying, there's no turning back. Okay, so understand that anytime an organ fails, that's it. Not much you can do about it, other than get another one. Okay, so this is why it's considered a life-threatening condition. Now, we will go over in detail the pathogenesis in a second, but cellular oxygenation may result from decreased cardiac output, so just like all the other things that we went over, so say a person undergo heart failure or some sort of valvular issue, whatever, cardiac output is low. If blood flow is not distributed properly, so let's say, for example, a person maybe has a blood clot somewhere and blood flow is being blocked, or reduce in blood oxygen content. So if there's a low oxygen content in blood, then that can also lead to this type of shock situation. Okay. So that's that. Now, this box, I do need you to know, please put a star by this. This box is also in your book, box 20-1. And this actually covers the 4 different types of shock. These are the 4 categories of shock, and then it goes into the examples underneath. Okay. I know it looks like a lot to memorize, but I'm going to go over this with you really quickly to show you that it's not that hard. So, cardiac shock or cardiogenic shock is anything, I don't want to say anything, but most things that have to do with the cardiac dysfunction. Okay, so anything that's sort of cardiac related will fall under cardiogenic shock, okay, such as an MI, cardiomyopathy, valvular diseases, okay, things like that all fall under cardiogenic shock. When you see the category obstructive shock, this is anything that can be physically, mechanically, or even fluid that's blocking blood flow. So anything that's blocking blood flow, so any type of obstruction that's blocking blood flow. Pulmonary embolism, okay, obviously that is a blockage. Cardiac tamponade, we haven't gone over that, but I'll tell you what it is. Cardiac tamponade is fluid that builds up in the pericardial sac. Cardiac tamponade is fluid that builds up in the pericardial sac. So it builds up around the heart. Okay, so it builds up around the heart. Now, why would that fall under obstructive shock? The reason why is because if you have a bunch of fluid around the heart's not going to be able to contract, and that's actually going to block flow. Okay, so they do look at it as a blockage. Tension pneumothorax, we are going to cover that in detail today. Okay, so tension pneumothorax, when a person has a collapsed lung, understand if a lung collapse, is it going to put pressure on the heart? Yes. And so when it puts pressure on the heart, that is also considered an obstruction. And then dissecting aortic aneurysm. Okay, so again, that will be another blockage if an aneurysm is in the vessel. Now, hypovolemic shock. This one is really easy. Anything that has to do with fluid loss. Okay, whether that's vomiting, diarrhea, blood. Okay, so any type of fluid loss falls under that category. Hypovolemic. Distributive shock, this one has to do with, this is more nervous system related. Okay, this one is more nervous system related. And I'm going to go over that in detail a little bit. Now, the pathogenesis. Now, the pathogenesis is actually quite interesting, okay? When you see these sort of arrows here, they have them like kind of separately, but they all kind of fall into each other. So they really should be kind of like listed 1, 2, and 3, or they flow into each other. So let me just explain. So again, here's the scenario. Let's say, for example, we have a person that's undergoing anaphylactic shock, okay, or anaphylaxis. They ate some peanuts, okay, or whatever the situation is. Now with them having that issue, this actually stops blood flow in circulation, okay, with the anaphylaxis. So if it stops blood flow in circulation, what's going to happen, there's going to be a lack of blood flow getting to the tissues. So what is happening at the tissue level? What is happening is that it will undergo anaerobic metabolism, okay? Why? Because they're not getting enough oxygen, so the cells will undergo anaerobic metabolism. When we undergo anaerobic metabolism, what is a result that we know happens from anaerobic metabolism?
We get lactic acid.
Very good, lactic acid. So this is something I want you to jot down. These patients will definitely have an increase or elevation of lactic acid, okay, when the tissues are starting to die, so to speak. Okay, so elevation in lactic acid they will have. Now, once we have that elevation of lactic acid, okay, and we don't have, obviously, ATP because we don't have oxygen, so we're not making ATP, which means we need ATP, as you know, for the cell membranes, correct? Okay, for the ion pumps to work. So if you're not getting ATP, the cell membranes and the ion pumps are not working, which means that ions are just going all over the place. When ions are just going all over the place, what's going to happen is this. It will eventually go into a state of making free radicals. I don't know if you guys went over free radicals in chemistry or maybe physiology, but free radicals are what we call unstable ions. Free radicals are unstable ions. And when we have an unstable ion, understand that that's not a good thing. That's actually a poor thing, because that means unstable ions are actually going to cause more damage. Okay, they're actually going to cause more damage to that cell, to that tissue. Now, once we have free radical production and they're just doing their thing, okay, causing a problem, understand that the body recognizes this. Okay, so the body's just not going to sit there and allow things to occur. That's wrong. It will try to correct it. And the way it corrects it is by sending the immune system over. So now we will have macrophages that will come. So you have macrophage induction. Well, that sounds like a good thing. Maybe the macrophages can come and get rid of the free radicals. Sounds nice, but unfortunately, macrophages do come over, and because of the destruction that's occurring, they come over in a very high number, and they actually cause more destruction. So that's the problem. So macrophage induction, they're doing what they're supposed to do. However, it will result in more destruction of the tissue. So all of this is kind of like a double, triple whammy, okay, all together. So once you have all that, what you should understand, if you can visualize, is that this tissue is now just being destroyed, okay, and that leads to that. So failure of microcirculation to autoregulation, okay, of blood flow, which we talked about, I believe, with chapter 18, okay, as far as microcirculation. And we know if microcirculation is off, this is definitely going to offset how blood flows through circulation everywhere, okay? And so this can lead to coagulation. Here's a diagram, and again, I think I left these diagrams in here for you, yes. I left these diagrams in this PowerPoint, again, for those people who do like flow charts. This looks all kind of crazy. They could have laid this out a little differently. However, those of you who do like flow charts, if you can follow it, it's there for you. Okay, but I'm not going to go over each and every flow chart. And I don't have flow charts on our actual exam, so it's not like I'll be tested right from that. Okay, so this particular slide covers the compensatory mechanism. Okay, so I'm going to repeat this. We talked about this the last time we met. And I'm going to say this one time with this lecture, but you'll see they talk about the compensatory mechanism for each and every shock. And so the main focus here is that you should understand that the compensation is something that continuously occurs. Okay? So even if the body's undergoing heart failure or shock or whatever it is that's happening, the body will always try to compensate and try to correct it. Okay, now unfortunately we know it doesn't correct it 100%, but the body will always try its best. Okay? That's the beautiful thing about the human body. It will always try to correct an abnormality, okay, which is why we went over that in chapter 2. Okay, so, all right, compensatory mechanisms and stages of shock. Okay, so the compensation is this, and I think we all know. If you do have insufficient amount of blood, okay, getting to the heart, or just say any tissues, this will lead to a reduction of cardiac output. Okay, so once cardiac output is low, okay, what do we know is going to be the activation? What's the activation? Sympathetic nervous system. Very good. Please make sure you know that and know that forever. Okay, sympathetic nervous system will be activated, and it will send a signal to the heart, to the bloodstream, to tell everyone, hey, let's get this working. Get the heart pumping. Let's pump out some blood, okay, so we can now get back to normal. Okay. So the body will always, always undergo that compensation. And again, that's that. Now, this particular slide pretty much covers the same thing I already said earlier about the anaerobic metabolism, lactic acid produces ATP, leads to the cell death, and this also causes free radical production and so forth. Okay, so we already went over that, but just in another form. Okay. Do you have this table?
We don't have
Oh, you don't? Okay, something happened. I don't know what happened. Oh, maybe I gave you guys an abbreviated version.
We'll jump straight to
I'm sorry. Let me look at this 20. Oh, you know what? I'm sorry. I'm looking at the whole PowerPoint. Does the top of yours says 416, 215? 2015?
No, that's 11, 17.
15?
Oh, just goes from
Maybe, is it a page missing?
5 to 9. From 5 to 9 we jump.
Oh, okay. Is everyone's PowerPoint like that?
Yeah. It just goes from this table to types of shock, cardiogenic shock.
Okay.
Yeah. So it's just in between.
You guys have the right PowerPoint. That's not the problem. It's just that I made an abbreviated version for you, and I don't have the abbreviated version. That's the issue. I'm looking at a different version. So let me go back.
It goes from slide 5 to slide 9.
So it has this,
Yes.
but not that.
No.
Okay.
No.
Okay.
No.
And then that. Okay. All right. So 6, what you're missing is something that we know already. Okay. So we know this for any cardiovascular condition, so you don't have to worry about that if you don't have that slide. This is a repeat of what I already just explained, so that's okay. This you don't need, which is probably why it's out. And then we just going straight to you. Okay. So let's get with cardiogenic shock. So cardiogenic shock, as I explained to you, this is a type of shock that has to do with most cardiac disorders, okay? So say a person has a heart attack, they're having a myocardial infarction, okay? And we think, oh, the person's gonna die just from that. Well, what can happen is this person could undergo a type of cardiogenic shock that could lead to the death. Okay, so then that's how it would flow. So this usually will result from a severe ventricular dysfunction associated with an MI, okay, which is what I just said. So just know that MIs can definitely lead to a type of cardiogenic shock. So diagnostic features, we already know that yes, they would have a decreased cardiac output. They could have elevated left ventricular end-diastolic pressure. So when the blood that's trying to leave the left ventricle cannot leave, there's going to be a higher pressure. Okay, so understand that the heart cannot contract and push out the blood that it normally would. Okay, so there's going to be more pressure in that ventricle. And then they would also have S3 heart sounds. Okay, S3 heart sounds. S3 heart sound, I think we already know that this is associated with a murmur. Okay, so S3 and S4 are abnormal heart sounds that are heard when patients are undergoing cardiovascular conditions. And these patients can also have pulmonary edema. Why? Because blood is not escaping the heart or leaving as it should, which means can this back up blood in the heart? Yes. Can this back up blood in the pulmonary system? Yes. So this can lead to pulmonary edema. Okay. And do you have this slide? Mm-hmm. Okay. So the first bullet here talks about the low cardiac output. Okay, we're not going to talk about that over and over again. We already know what's going to happen. Now, the third P goal is this. So I'm not going to have you memorize these last 2 bullets so you can kind of really cross that out. I'm not interested in you knowing, okay, what type of procedure and device that they're going to use. But I do need you to know what is the third P goal. The third P goal is aimed at improving cardiac output. Number 1. If cardiac output is low, the very foremost important thing is you want to increase that cardiac output. You need to make sure that that patient has adequate blood flow, as well as myocardial oxygen delivery and decreasing the workload on the heart. Those are the most important things. Because once that's settled, then everything else will be back to normal, hopefully. Okay. So that's that. You don't have this, do you? No. Okay. So I took the, okay, don't worry. I took the flow charts out because I don't really need them. Okay. Now, obstructive shock. I think you guys have this one. Okay. So obstructive shock, as I said to you before, this is a mechanical defect. I should say defect, but a mechanical obstruction that occurs to where this will block the flow of blood. Okay. So most common causes, which we went over already in that table: pulmonary embolism, cardiac tamponade, and tension pneumothorax. How do you treat this? You have to treat the underlying cause. Okay, so please make sure you know you have to treat the underlying cause. That is the main thing. If it's a pulmonary embolism, take care of the embolism. Okay, so this can stop the shock from occurring. Now, hypovolemic shock. I know you have this one. So for hypovolemic shock, there's some information I have to give you here. I do need you to know all the causes. Okay. So just in its title, as we can see, hypo, okay, less or decreased volume, okay, leading into a lack of blood flow, okay. So understand, when a person loses blood, I think obviously that would make sense that that will slow down the blood circulation getting to organs and tissues. But understand, when a person loses fluid, that is also extremely important as well. What is one of the main things they're giving to patients in the hospital? IV fluids. Why? Because it helps with circulation. Okay, so understand that IV fluids are necessary because as well as we keep up the normal blood volume, that will also help the normal blood volume circulation as well. Okay, so when a person undergoes something like excessive vomiting and diarrhea and things like that, could that offset circulation? Yes, it can. Okay, so let's go over the, even though they have some listed here, I do want you to jot down what I have here. So let's go over some of the things that can lead to hypovolemic shock. Okay, so one, we can have a patient that has internal hemorrhage. So an internal hemorrhage could do it. A fracture of a long bone. Okay, and I've actually have heard stories of this. Patients having a fracture and then leading into a hypovolemic shock, not knowing, because we know when a person fractures a bone, bone is actually very vasculature. It has a lot of vasculature. People sometimes forget that, and they can have a lot of bleeding that can now lead into that type of situation where it's an internal bleed. Leakage of fluid into interstitial spaces. So let's say, for example, if something is off with the lymphatic system somehow, where there's excess fluid and things just leaking out. External hemorrhage, okay, which I think we would definitely imagine. If someone has like some sort of puncture to the skin and it bleeding out excessively. Burns. Why do you think burns would fall under hypovolemic shock? What is happening when a person has severe burns? They're getting dehydrated, but what is
The skin.
the skin, and what is it that they're lacking out of the skin and the tissue if you're burning it? That's also a decrease in fluid. Understand that fluid is also made up in tissues in all our organs. So once you burn the tissue, burn the skin, that's actually now taking away the volume, okay, of fluid that they have, okay, which also leads to the dehydration. And the last thing, severe vomiting and diarrhea. Severe vomiting and diarrhea. Okay, so say for example someone has some kind of condition like a C. diff or something like that. Okay, having a really bad infection, vomiting, diarrhea, excessive can lead to this. Okay. Oh, and one last thing I have. Diuresis. D-I-U-R-E-S-I-S. D-I-U-R-E-S-I-S. Diuresis. Diuresis is an increase in urine production. Okay, so that's an increase in urine production. So if that occurs, obviously, that's leaving out. Now, they say the most common cause of hypovolemic shock is external hemorrhage. External hemorrhage is the most common cause of hypovolemic shock. so although we have the others. Now, so we went over all that. Now, this again is talking about the compensation. We're not going to be talking about that, but it's big. I'm quite sure you don't have that diagram. That's okay. Now, how do you treat hypovolemic shock?
Fluids and blood.
Give them what they lost. Very good. So if they lost blood, give them blood. If they lost fluid, give them fluid. Okay, most of the time, even with the blood, you give them fluid too. So just keep in mind you want to replenish them with fluids and blood products, okay, that they may have lost from the situation. And that's pretty much that. I'm not going to get into colloids and crystalloids and types of fluids that you give. You'll get all that in nursing when you give it for what situations. But just understand fluid replacement. Okay. I know you don't have that, and that's something that's omitted. Okay, so now distributive shock. Distributive shock is what is called excessive vasodilation and peripheral pooling of blood. Okay. Now, just imagine if you have a blood vessel that stretches out like this. Do you think blood's going to flow? No. Okay. Understand, we would think that, oh, if it's wider, that we would have a nice opening for blood to flow. Unfortunately, if you have it dilated too much, there's not enough pressure that exists for blood to move forward. So you don't want excessive dilation. Okay, so this is what we're talking about, excessive dilation here. Excessive dilation. So that would be an issue. So if you have excessive dilation, that means that that blood has no pressure in that vessel to push it forward, which means that now this will lack the amount of oxygenated blood flow getting to the organs and tissues, okay, for that person. Now, there are a couple of types of shock that fall under distributive shock: anaphylactic, neurogenic, and septic. Septic is probably the most common shock. You'll probably see that as well as anaphylactic, or I should say hypovolemic. So we'll go over these in detail. Now, for anaphylactic shock, this is what happens. Person, let's say, eats some peanuts or strawberries and they're allergic, okay, or shellfish or whatever it is. What's going to happen is this. We know that when that person's body comes into contact with that allergen that they're allergic to, the body is going to undergo what type of hypersensitivity? Type 1, very good. So when it undergoes that type 1 hypersensitivity, they will definitely start to secrete mast cells, which we know. They will also have IgE antibodies that are secreted because that's all a part of type 1 hypersensitivity. So when the body comes into contact, or I should say their response to that antigen is this. When that person eats that shellfish, okay, the immune system recognizes, hey, this is an issue. It's going to start to send over all those cells and mast cells to degranulate, histamine to be released and all that. All of that activity requires the vessel to actually dilate. So understand why the vessel's dilating in the first place. It's dilating because it needs to have adequate room for all of those immune cells to come over. The problem is this: because it's a type 1 hypersensitivity, it's not going to just dilate like this, it's going to dilate like this. Okay, because remember, everything is heightened to like the 10th power. And so this is the issue that leads these patients into this type of shock. Okay, it's this excessive vasodilation. So when they have that vasodilation, this will lead to severe hypotension, meaning that the blood pressure in that vessel is low, meaning that there's not enough blood to push forward. So, signs and symptoms when a person is undergoing anaphylactic shock. Okay. Urticaria is a clinical term for hives. Okay. So sometimes those hives can be itchy, sometimes they're not. And if you've ever seen anyone or experienced anaphylaxis yourself, you'll notice that, they'll just break out in the hives. Okay, and so this is what we call urticaria, the hives that just pop up on the skin. Bronchoconstriction, we know, is something that can also occur, which is something we don't want, which is why anaphylaxis is treated, okay, immediately, because we don't want the bronchi, okay, to close up. Stridor is a term for noisy breathing, okay, as well as wheezing. So they'll kind of have that together, wheezing and noisy breathing. And itchy, okay, itching, okay, on the skin, again, can be accompanied with the hives. Sometimes the hives can just pop out without the itching, okay, so it just depends. Now, another thing I want you to know, which is not listed here, these patients will also have an increase in heart rate and an increase in respiratory rate. And the reason why is that's for the compensation. Increase in heart rate and increase in respiratory rate, and that's due to the compensation. And just like when we talked about hypersensitivity type 1, these signs and symptoms do develop within 2 to 30 minutes of exposure. So these signs and symptoms will develop within 2 to 30 minutes of exposure. Okay, so very quickly this will start to occur. Now, how do we treat this? I think we all know the common EpiPen and epinephrine, okay, is commonly used for this. However, antihistamines can also be used, vasopressors. And what is a vasopressor? This will actually cause the vessel to kind of constrict, okay, because the vessel's like this, okay? We don't need it to stay that way. We need it to constrict. So it'll cause the vessel to constrict and definitely give them fluids to help with movement. Yes?
What about steroids?
Yeah.
Steroids can be given. I don't know if it's used like in an anaphylaxis, like an immediate situation.
So long-term treatment.
Well, long-term treatment, yes. Long-term treatment after. It'll help kind of keep everything
I think the
constricted.
reason why they don't use steroids is because of the compensation of the increased heart rate. You don't want to increase it even more to overwork the heart.
I was just thinking of like the anti-inflammation that the steroid
Yes, but not immediate. Not in an immediate situation. Just imagine these patients undergoing anaphylactic shock, so you don't want to give them something that's going to make them, how should I say,
you want to increase the tachycardia.
more increased tachycardia. We don't, because that's what sometimes it'll do. That could be used more long term if they're having respiratory issues to kind of keep it.
Yeah, epinephrine kind of does that too, doesn't it?
Epinephrine,
Epinephrine also
not
vasodilates.
really. It depends on the person. It depends on how they react to it. But I don't think it has a side effect of tachycardia. But you've seen this before?
Yes, I've worked with many of these drugs.
So epinephrine,
We
you've
usually
seen.
give bronchodilators as well to dilate the bronchioles. Epinephrine is usually the choice of medication. It's not to increase the heart rate, only because the heart rate is already compensating
Right.
enough. We don't want to overwork the heart.
Right,
So epinephrine is usually given to vasodilate the veins, the vessels as well.
right, and to calm down the immune
Yes.
function. That's what epinephrine is used more, so to calm down those mast cells and things like that, as well as the antihistamine. But sometimes when patients, and this actually happened to me, when you eat a piece of shellfish, and I ate shrimp not too long ago, and I didn't realize that I was having this issue, and so I broke out in hives. And thank God I had some Benadryl, so I just took some Benadryl. And so you can kind of use that as an immediate, the antihistamines, if you don't have anything else. But if they do have access, I'm quite sure they'll use the epinephrine over antihistamine, okay, because it's a little stronger. So, okay, that's that. And then another thing that's quite interesting, I don't know if this is the law in California, but in New Jersey, I remember that a lot of the school nurses were not able to give the EpiPen to the children. And so they had to instruct the children on how to use the EpiPen themselves, but the nurses couldn't administer the EpiPen. So I don't know if that's the law here in California, if anybody's interested in being a school nurse. But the school nurses, they are limited to certain things of how they can treat children. And so this was one of them, administering the EpiPen. Okay. So, neurogenic shock. Okay. So with neurogenic shock, this particular one is when patients lose the sympathetic activation, which means that if they lose the sympathetic nervous system activation, this will unfortunately cause the vessels to just kind of dilate. okay? So when sympathetic activation, if you think of what it normally does, is to like increase blood flow, and so it's going to cause constriction and a contraction of the heart. This is going to do the opposite. So if you lose sympathetic nervous system activation, it's actually going to dilate or lose that ability to constrict. So how can this occur? This can occur definitely in cases when patients have brain injuries. So people that may have certain types of accidents where spinal cord injuries, okay, things like that could unfortunately lead to this. Even drug overdose, okay. Sometimes what happens when people die of a drug overdose, sometimes they think, okay, it's a toxicity. Yes, that's part of it. But sometimes the drug overdose, the toxin can actually shut down the nervous system, okay, which leads to this. So if this occurs, vasopressors again and fluids to increase that flow. Okay, and then the very last shock here that we're going to cover, septic shock. So, septic shock, if you guys don't know, and I'll tell you this, is the most common cause of death in intensive care units. Okay, unfortunately, you will see it. And even there's an online patho class for the people that are doing their masters. And so in the online patho class, they have a video on Blackboard. It's a long video explaining the whole thing about sepsis, okay, and septic shock. And I'm quite sure you guys will get a lot of education in that when you get into nursing corps. But what is this saying? They say if you want to get sick, go to the hospital, okay? And so it's true because every germ you can think of is there, okay? So just imagine the situation if you have a patient that's already immune compromised for whatever reason, okay, whatever's going on with them. And especially when you have patients that are in intensive care. They're in intensive care for a reason, which means that they are in a critical state. Maybe the blood flow's already not flowing. Maybe there's some sort of cardiovascular issue, respiratory issue, okay, whatever it may be. And so now you have this patient that's vulnerable, and now they can be exposed to infections, okay? What are the most common ways patients can get infections if they're in a hospital? Just take a guess. Catheters. What else? IV sites, okay? Which I was watching this video and it was actually really good. It was a doctor explaining how they were doing a training with all the nurses to make sure that the IVs were changed in a timely fashion, okay, checking things like bed sores and, you know, catheters and any type of placements, tubing, okay, things like that. Make sure those things are changed in a timely fashion and taken care of because unfortunately those are the sites where they get infections, okay, and they can get it easily. The problem is this, when that infection is presented into that patient, it can progress very fast. Why? Because they're already in an immune compromised state. Okay, so it can progress very fast, and sometimes these things are taken care of in a timely fashion, which leads to the sepsis, leads to the septic shock, leads to death. Okay, and sometimes, you know, people will come in and say, "Oh, why did my loved one die? What happened?" And it was just from the infection that took over. Okay, so very important. Okay, so most common causes of septic shock are going to be bacterial infections. Okay, bacterial infections. Some fungal, but mostly they say more common bacterial infections. So bacteria and fungal. You don't have to memorize gram-negative and gram-positive. You need to know that, but just know bacterial and fungal. Do you have this slide? Okay. So, what happens is this, and I'm just going to explain this and sum this up for you. Person gets an infection, let's say at an IV site. Okay, the infection spreads in the bloodstream, obviously, okay, at that site. When that infection spreads in the bloodstream, what's going to happen is this. The body is going to undergo the immune response. Everything's going to try to come over and fight it. However, when it's coming over to fight it, just imagine that it will vasodilate. Okay? And keep in mind, we're talking about bloodstream, meaning that now this infection is not just here, this infection is now systemic, which means it's all over their body. So this is a widespread systemic infection that takes over their body, which means that now this whole inflammatory process is occurring all over everywhere, okay, which makes this even more deadly.
And antibiotics aren't that effective for
Well, this is what happens. So usually sometimes depending on, and don't quote me on this, but from my understanding, once patients are like kind of post-op and depending on what is going on with them, they will do IV antibiotics just to make sure that this doesn't occur. So sometimes this can be prevented, or let me put it this way. In the video that they have for the online patho class, in the video they were showing how the nurse actually discovered the patient's, the beginning signs of an infection. She didn't chart it, she didn't make anyone aware, and it wasn't treated. And the next day or two, that patient was in ICU, and then the next day after that, the patient died. So the thing here is that it has to be taken care of immediately. So if you see any signs or symptoms of infection, you don't want to wait and see, okay, well, what's going to happen the next day. You want to take care of it right away.
And is it harmful to have an antibiotic, even though they don't have the infection?
No. A lot of times they do it just as a prophylactic. A lot of times. A lot of times, depending on what's going on with that person, especially if they're immune compromised, whatever's going on, cancer, okay, things like that. So yeah, they'll do it as a prophylactic. But not everyone gets it. It just, because it's kind of hard to pick up immediately. So it just depends. Okay. So again, just to explain that it is a widespread systemic infection, inflammation process that's occurring, okay, everywhere in the body. I don't think you have that. No, you don't need that. Okay. Do you have this slide?
No, we don't.
The next one,
25.
Okay. This is just talking about the compensation again, which we already know. Okay. So, therapy is aimed at improving the blood flow. And yes, as we just discussed, giving them antibiotics. Okay, so yes, you can give them antibiotics. Again, it all depends on the severity, okay, of the infection, how far has it gone, okay, to that point. And give them fluids, okay, and whatever drugs you need to keep their cardiac flow going. I know you don't have all that. Do you have complications of shock?
Yes.
ARDS.
31.
yes.
So, complications of shock. Now, what happens is this. Sometimes shock can lead to organ failure, okay, or it can lead to other conditions. We're going to go over ARDS in detail in a little while, okay, in chapter 23. And ARDS is acute respiratory distress syndrome. So always understand when a person goes into respiratory distress, a person usually doesn't just fall into respiratory distress, okay, out of the blue. It's usually due to some sort of primary condition, okay, something else. So what happens here is that, say for example, if a patient is undergoing a septic shock, obviously not getting enough blood flow and circulation, not getting that adequate blood flow to the pulmonary system, this can lead them into a respiratory distress. Okay, so that's how that works. I'm just going to give you just the surface of each syndrome, so I'm not going to get into a whole bunch of detail with the pathogenesis, but I just need you to know exactly just what the condition is. Okay, DIC. I think we talked about this. One in 14. So DIC is disseminated intravascular coagulopathy. Okay. Now, what is this? If you remember, this is where a person has that excessive bleeding, hemorrhaging, and clotting at the same time. Okay, so we would imagine that, say for example, if a person has hypovolemic shock, say they had some sort of injury, okay, where it's a puncture, they're bleeding out, bleeding excessively, to the point that now they could fall under this type of situation, okay, where they would bleed and clot excessively. Acute renal failure. Now, why would this be a complication of shock? Well, the reason is this. 1/3 of blood gets filtered through the kidneys, okay, which we know, which means if you have a person that's undergoing shock, which means that they're not getting blood flow, if you don't have that blood flow getting to the kidneys will suffer, okay? And so now this patient can go into kidney failure, okay, because of the lack of blood flow. So that's that. And the very last thing, multi-organ dysfunction syndrome, or what I call multi-organ shutdown, which is very common with sepsis and septic shock. And so what happens, these patients, again, a widespread systemic inflammation all over the body, leading into multiple organs failing. Okay, and when multiple organs fail, again, the only thing you can do is try to manage whatever can be managed at that point, but unfortunately, these things could lead to death. So that's that. All righty. I think this is a good time to take a break. We're actually doing okay. Yes. So, yeah, what'll happen is, yeah, organs will start to fail, like multiple organs at the same time. Which, yeah, sometimes I call it well, yeah, they call it different things. Sometimes you may just hear it as multi-organ shutdown or failure, multi-organ failure, but it's just the organ system that's failed. Yeah. I'm sorry, give me 1 second. Okay. So believe it or not, we are done with cardiac, and we're moving on to respiratory. Okay. So cardiac disorders or cardiovascular diseases, those chapters are split up into 4 different chapters, kind of. Cardiovascular is split up into 4 different chapters. Respiratory is actually split up into 2 chapters. Okay, we have what is called obstructive pulmonary disorders, where there's a physical obstruction blocking the airway, as opposed to when we talk about restrictive pulmonary disorders, this is more having to do with a restriction around the alveolar level, okay, or something with the lung parenchyma. So, let's start with 22. Now, this particular chapter, as you can see, I think it has, what is it, like 70 slides or something? 89. You guys have 70 slides?
Yeah.
I think, okay. This chapter is long, and the crazy thing is this, it only really covers 4 disorders, but it goes into a lot of detail with the pathogenesis. And I do want to break down the pathogenesis for you because it is important to understand, because COPD is very common, you'll see it, and so we do want to take our time with this. And so if we have to take a break in between, we will. Okay? But it is a lot of information. Now, I wrote on the board here COPD, and I broke it down for you. COPD is considered to be chronic obstructive pulmonary disorders. Chronic obstructive pulmonary disorders. Okay, and so sometimes when you hear, sometimes they'll just use this term kind of loosely as a diagnosis. Oh, the person has COPD. Okay. But then it's like, okay, well, which one? Because what happens, COPD, it is a set of disorders, okay? And so to give you the disorders that fall under that category, it's really a category. Asthma, believe it or not, falls under that category, okay? When we think of asthma, yes, we do think of it being an acute situation, an acute asthma attack. However, asthma is considered to be a chronic pulmonary disorder. It's usually chronic in an individual. Chronic bronchitis is another one, which we know. And emphysema. Okay, emphysema, which is the worst of the 2, or all the 3. So, but when you hear COPD, they do usually mainly focus on chronic bronchitis and emphysema. Okay, so just to let you know that, they usually just focus on those 2. However, asthma is considered a chronic disorder. Okay, I don't want you to think it's just acute. Okay, now, obstructive pulmonary disorders. Okay, so I think you guys have all the slides for this one. You have the slide? Okay. So what happens here, when we talk about obstructive pulmonary disorders, again, think in your head obstruction. So something obstructing, blocking airflow. Okay. So it is classified, they have 3 different ways that this can occur. Obstruction from conditions in the wall of the lumen. So just imagine the wall of the lumen, say for example, if we have, like say, a mucus gland, okay, in the lumen that gets larger, or some part of the lumen gets larger. If the lumen gets larger in a state of hypertrophy, understand that that's going to decrease the lumen size. Okay, so therefore that will be a blockage, okay, of airflow. Obstruction resulting from increased pressure from the outside of the airway of the lumen. Very good example of this. You know how when you look at the bronchi, okay, it actually has muscles surrounding it, if you remember from anatomy. So just imagine if those muscles go into a state of contraction, okay? If those muscles surrounding the bronchi go into a state of contraction, that's going to also decrease the lumen size, okay, and therefore block airway. And if there's some sort of physical obstruction right in the airway, lumen. And a very good example of that would be mucus. Okay, mucus is one of the most common things that do form in a lot of COPD conditions. And if mucus is just sitting there in the airway, that will block airflow. Okay, so these patients can't breathe. Okay, so the very first thing we're going to go into is asthma. And there's a lot to say about asthma. So we'll go into this. Okay, asthma is considered to be an airway obstruction that is reversible. Please make sure you highlight reversible. And when we say reversible, that means it's reversible on a cellular level. Okay, it can be reversible on a cellular level. And we're going to go over the complete pathogenesis and break it all down. Okay, which means that what's occurring on the cellular level in that person that has asthma in the bronchi, down in the lungs, it can be reversed. It is considered an airway inflammation. When people think of asthma, they think of, oh, yes, it is a respiratory condition, and they're thinking, oh, well, something's wrong with the lung. But what is the initial issue with patients that have asthma? It is an actual inflammation. So something is causing the airway to get inflamed. And it's usually some sort of, not always an external situation, but most of the times it's an external stimulant, which we'll go over some in a little bit, sometimes internal. But understand that it is really an inflammation. If that inflammation didn't occur in the first place, the patient wouldn't have asthma. Okay, so it's the inflammation that's the issue. And increased airway responsiveness to a variety of stimuli, okay, which we'll go over the stimuli in a second. So here are some stats. I'm not going to hold you responsible for memorizing the stats, but they do have some percentage there. They do say it is the most common chronic disease in children, okay, which we do know children have more high cases of asthma, although, however, adults also have high cases of asthma as well. We'll go over the different types. Now, so predisposing factors. So you know how you hear the stories where people say, okay, well, it runs in my family. Okay, my dad has it, my granddad had it, okay, and so now I'm going to have it. So the situation is this. Asthma is definitely hereditary, and so what happens, these patients do have a genetic coding for what is called atopy. And I'll give you the definition of atopy. Atopy means immediate hypersensitivity reaction. Atopy means immediate hypersensitivity reactions. So atopy is immediate hypersensitivity reactions. And they say also these patients structurally have smaller airways. Okay, and so that's also hereditary, that they're just born with smaller airways. Okay, so with the atopy, they even know the chromosomes 5, 11, and 14. Okay, so they know the exact chromosomes where these patients do have this genetic coding for hypersensitivity, okay, reactions. So, history of hay fever and eczema is accompanied sometimes with asthma. I don't want to say each and every case because I don't want you to think, oh, if a person has eczema, they're definitely going to have asthma and vice versa. However, it is quite common, okay? and family history, which we talked about, and then the very last thing here, which is very key, is positive tests for allergens, positive skin testing. Now, what's going to happen is this. If a person has an asthma attack, and another one, and another one, and another one, at some point, they should be going to an allergist to see if they are what they're allergic to, okay? Because there's something that's triggering that whole inflammatory response in the first place, okay? So they really should have some sort of testing done. Okay. So this chart, or I should say chart, slide goes into extrinsic, or what we call the allergic form of asthma. So I want you to know that there's actually two forms of asthma. We have what is called the extrinsic type, which is the allergic type. This one is the most common type. But then we also have something known as the intrinsic. It's not in your PowerPoint, but they do talk about it in your book. When I test you, I usually just focus on the extrinsic type, the allergic form. But I do just want to make you aware of the intrinsic form. Okay. Okay. So the extrinsic form is what we call the allergic type. Okay, so which means that there are going to be some sort of external, environmental, outside triggers that are going to trigger this person into leading into an asthma attack. So you guys may know this. What are some triggers that you know could lead a person into an asthma attack?
Freshly cut grass.
Yes, definitely. Cut grass. I'll just put grass.
Cat dander.
Pet dander.
Smoke.
Smoke, definitely. Smoking. Smoke inhalation is not good. I feel sorry for the people, God bless you, that work in casinos.
And
It's
it's sometimes also like perfumes or alcohol based.
Yes, very good. Sometimes, yes, fragrances, okay, certain perfumes can definitely cause an individual to undergo that inflammation, okay, from the smell.
Pollen.
Pollen, very good. What about weather conditions?
Yes,
Yeah,
like-
windy.
Wind, and especially here in this region, wind, because the wind kicks up what? The dust. Also leads to that. And another thing about weather conditions that is harmful to asthmatic patients is heat. Very good, the heat. Understand that extreme heat, and even sometimes extreme cold, but even more so extreme heat is definitely a no-no, because that can definitely trigger sometimes asthma.
I had a
Okay,
patient who went into asthmatic exacerbation because of extreme coldness.
because of extreme coldness, yeah. It can happen, it's not as common as the heat. The heat is more common, but yeah, definitely the cold can do it too. So those extreme temperatures can cause a person to go into an asthma attack. Definitely the dust, especially in this region where it's very windy and picking up the dust, and all of those things, okay? So the point here is that when we have any type of external, okay, environmental trigger, this, when they inhale, okay, these types of things, unfortunately, the body goes through this whole immune process, inflammatory process, so much to the point that it actually will start to clog up their airway, okay, and lead them into an asthma attack, okay. Now, so again, it's the inflammatory process. Now, for intrinsic, believe it or not, these patients do also undergo an inflammation, okay, so there's also an inflammatory process. However, the way it happens is different. So it has nothing to do with external environment, but what happens is it's usually having to do with how the nervous system relates to the vessels. Okay, so you may have heard of stress-induced asthma and exercise-induced asthma.
There's also URI-induced asthma as well.
Which one?
URI-induced asthma.
URI?
Yeah.
I've never heard of that. What is that one?
Upper respiratory infection.
Oh, upper respiratory. Oh, okay. Upper respiratory infection, asthma. That falls under in extrinsic.
Would it be
Upper respiratory infection. That
Yeah,
might
when
be
the
that might be
patient gets sick.
extrinsic.
would it be extrinsic?
I think that would be extrinsic because it's whatever's from the outside. Well, from the initial infection is something external. And you know, I'm glad you said that because that situation just reminded me. These situations here sometimes can come from patients that have respiratory infections that go untreated. Because sometimes people have colds and then they'll continue having a cough and all that going on, leading into possible bronchitis. And we're going to talk about bronchitis in a little bit too. And then unfortunately, not having it taken care of, and then now leading into this whole process where they have continued inflammation, continuing a blockage of the airway, now leading into that type of asthma. Okay. Yeah, I'm glad you said that. I forgot about that. Okay, now with intrinsic stress-induced and exercise-induced asthma, this has nothing to do with an immediate external type of situation. So it's not a bacterial infection, or it's not a smoke or anything like that that they're inhaling. The problem is this: when they undergo a certain amount of stress, it will now trigger the body to undergo inflammatory changes. And these inflammatory changes will happen, unfortunately, in the pulmonary system. Okay? And we talked about this a little bit with chapter 2, how when stress-related conditions can occur. Okay? Exercise-induced asthma is pretty much the same philosophy here too. When we have a person that is exercising, excessive exercise can also cause a little bit of strain on the nervous system for that moment and lead them into that type of induced asthma. Okay, so that's that. But again, we're really going to focus on extrinsic, just the allergic form, but I just wanted to introduce that form to you. Okay, so going back to this, extrinsic or the allergic form, about 1/3 to a half cases of asthma. And IgE mediated, which we know, okay, because asthma we already know falls under that type 1 hypersensitivity. Clinical manifestations in their blood, you would see elevated IgE levels. Allergic rhinitis is just a term for runny nose. So they're going to have a runny nose, congestion in the nose and runny nose, things like that because of the allergy. Eczema, if possible, if it happens. And family history allergies, which we know. And these attacks can be seasonal, environmental, occupational. Sometimes patients that do work in certain conditions, okay, like I was saying, if someone works in a casino or working in a factory with a bunch of smoke and things like that, or dust, they may not be able to work in that condition because of those conditions. Okay. So, let's go through the pathogenesis here. Pathogenesis is quite long, but I'm going to sum it up. So, mechanism of action. So let me give you an example. So say, for example, I always use this example. Someone is allergic to cats. Okay, they go over their friend's house that has 4 cats. Okay, they're sitting there and bearing with it. Okay, so if this person now that's allergic to cats are exposed to cats and they're sitting in a room full of cats, and now they're inhaling, okay, all of the things that they should not be inhaling, okay, because they're allergic to. So what's going to happen is this. Once the body comes into contact with that particular antigen that they're actually immune to, like I say, allergic to, what will happen is that the body will immediately recognize, hey, this is something we are allergic to, we don't want it. Which means that the immune system will now start to secrete mast cells. Okay, mast cells will be secreted. Okay, previously synthesized mast cells in the airway, they will be secreted. And when we have mast cells, when they come into contact with that antigen, once that occurs, they will start to degranulate. And we know when mast cells degranulate, what happens? It releases what? Say that again. What does it release?
Histamine.
Histamine. So it's going to release chemical mediators. Okay, so we go to the next slide. In particular, yes, histamine, which is at the top of the list. Okay, so histamine, we do have some leukotrienes, prostaglandins, bradykinins, so all that good stuff, okay, that needs to be released because, hey, we need to fight this particular allergen. It's not supposed to be in the person's body. So when histamine is released, I think I explained this to you guys before, this actually will start the patient's signs or symptoms of allergies, okay? The watery eyes, itchy nose, scratchy throat, all of that because of the histamine release, okay? And so that's a normal process, and that's that. Now, this diagram, do you have it? You don't need to know this diagram. Okay. So, moving on. Another thing that occurs is this. They say normal respiratory epithelium is denuded or stripped, and replaced by goblet cells. Well, I don't really like that term, replaced, because does a respiratory epithelium normally have goblet cells in its epithelium that you remember from anatomy? Yes, it does. Okay. And goblet cells do what? What is their function? To secrete mucus. Very good. So why would we want to secrete mucus in the airway?
To get rid of any irritants.
Very good. To trap any type of irritants and debris or whatever it is that's in that airway. Okay. So the problem is this. We already have goblet cells, and so I would correct that sentence, and I would say that it's a hyperplasia of goblet cells. It's actually a hyperplasia, not that it is stripped and replaced. It is a hyperplasia of goblet cells. So we have an excess number of goblet cells that are secreting. So the big picture here is this. Person is allergic to the cats, they're inhaling and sitting there, and so what's happening, the normal goblet cells that are secreting mucus to try to trap all that cat hair, unfortunately is actually going to go triple, double time. Okay, double or triple time. So now this person is going to have excess amount of goblet cells being secreted, which means they will actually have excess mucus being secreted to try to trap all that cat hair. And the reason why, understand, this is because that person is hypersensitivity, so it's heightened. So what's going to happen when they have excess mucus that's being secreted, you think that's a good thing, so you can try to trap everything. That's not a good thing, because now they have excess mucus in the airway. This is actually one of the very first things that occur as far as the pathogenesis that cause patients that are asthmatic to not be able to breathe because of that mucus. There's too much mucus in the airway from this process. Okay. So that's that. So, other things that can occur, they can have mucosal edema. So we know that edema can definitely come from the inflammatory process. Inflammatory exudates more fluid that can be secreted. Bronchoconstriction. Okay, so let's talk about that for a second. Bronchoconstriction. The bronchi will actually constrict. Okay, why? Keep in mind, they're sitting in a room full of cats. Okay, the body's not going to say, okay, well, let's just let it happen. The body is going to compensate by constricting. And the more that person is allergic or sitting around that allergen, the more it's going to constrict. Okay, so understand that that also leads to a lack of airflow. And leakage. The leakage we're talking about here is fluid. Okay, so some of that exudative fluid can leak and also trap up in the airway. Okay, along with edema of mucus. Okay, so late phase is this. The more this person is sitting around that environment and is not taken care of, are the more cells going to be secreted and immune cells going to be secreted? Yes. Which means that the more immune cells that's going to be secreted, the more damage that's going to occur to that person's airway. Okay. So understand this, and we've discussed this before. The immune system is wonderful and it's doing its job. However, it's only supposed to do its job for that moment. But once you have persistent I should say immune response constantly, unfortunately it's going to lead to damage. Okay, so that's the key thing here. Okay, it's just saying a little more what we discussed. Hypertrophy, smooth muscle, yes, it'll get larger. Edema, we talked about. Mucus gland hypertrophy, yes, mucus, we talked about that. Okay, So some of this again, bronchoconstriction we talked about, yes. Edema, mucus plug, yes. Now, here's a nice picture of it. I think you guys have this in PowerPoint. And so it's showing you normal. Here's the lumen narrowed. It's narrow. Why? Because it's going into that bronchoconstriction. It's going into that constriction. Edema is also surrounding in the mucosa, okay, and that's also causing more pressure on the outside. And here's the increased mucus glands. There's mucus also inside the airway, and the muscle around it is hypertrophied because of the constriction, the constant constriction. So the muscle gets thicker. So that's that. This is the histopathology. Let me get into this. Okay, let's jump down to the last sentence here. I do need you to highlight at least the last sentence. Most of that we already talked about. Okay, so the last sentence here talks about the inflammatory cells that are secreted. So this is important to know because, say for example, if blood work is done on a patient that has asthma, what are you going to look for? What is actually going to be elevated? So inflammatory cells that will be secreted will be neutrophils, eosinophils, and lymphocytes. Please put a star by eosinophils. That is kind of our hallmark immune cell that's being secreted here. Or I should say white blood cell that's being secreted are eosinophils. Eosinophils will definitely be secreted in the situation of an asthma. Common symptoms: wheezing, feeling of chest tightness, dyspnea, cough, and the patients can have excessive sputum production. The cough can be dry or productive, and it just depends on how much mucus is and if they're actually able to bring it out. Okay. The type of sputum, you guys will have a lovely time with that later on. Okay, looking at sputum and understanding the different types. Now, when a person's having a severe attack, they do use accessory muscles of respiration. So if you remember, what are your accessory muscles of respiration from anatomy?
Intercostals.
Intercostals, very good, as well as your SCM. Okay, so believe it or not, these patients kind of have what I kind of call a look at as like top breathing. So understand that they do have issues with full inhalation and exhalation. So when we exhale, we know it comes from here, below the diaphragm. The issue is they can't really get a complete breath out because it's a blockage, so it's these kind of short breaths, okay? So most of the work is going to be done with the intercostals and the SCM, so just to try to get a breath out. Orthopnea, which we know is difficulty breathing by lying down. Agitation, I always find that funny because I would think anyone would be agitated if you can't breathe. But agitation, I guess, comes from also the lack of blood flow. Okay, get into the brain and circulatory system. I should say nervous system. And tachypnea and tachycardia. Now, tachypnea and tachycardia, increased respiratory rate and increased heart rate. These two things actually are compensations. So they're part of the attack, but not really, okay? It's really a compensation of what's occurring. Okay, so diagnosis, physical findings, cough, okay? You see the coughing, wheezing, hyperinflated chest. Why is the chest hyperinflated? Okay, very good, air is stuck or trapped, so we have air trapping. So keep in mind, again, these patients aren't having a full, complete exhalation and inhalation. So they're going to have air trapping. So the chest will be hyperinflated. And decreased breath sounds. On chest x-ray, you can see that hyperinflation of the chest wall, the chest cavity. And you'll know that because the diaphragm actually will be flat and it'll be lower. Okay, which we know from anatomy tells us that there's air. A lot of air in the lungs. And with the sputum, what they look for in the sputum are something called Sharkin-Linden crystals. And basically what they are, they're kind of like dead eosinophils that actually crystallize over. Keep in mind, as I told you before, eosinophils are definitely the hallmark cell here. And so they do have excessive amount of eosinophils that will be secreted. So eosinophils, when they go through their maturation process and their lifetime or lifespan, they actually will die, okay, and it'll also come out in the sputum. They can also have mature eosinophils, and then something called Kirschmann spirals. Kirschmann spirals are just what we call mucus casts, and let me just draw this to explain. So if I can explain, it's almost like dry mucus. I know it sounds kind of weird that they're coughing up dry mucus, but this is the thing. So say this is the bronchi here, and say what happens here when mucus settles. Mucus can settle within the rings of the bronchi. We know that it has like that ring arrangement. So when the mucus kind of settles in the rings, and so when they get to a situation where they do have a productive cough, they will cough out the mucus that just kind of dried up around that area. Okay, so that's what we call Kirschmann spirals. Okay, pulmonary functional testing. Did I take that out? Do you have the slide? You have it? Okay. I'm going to omit pulmonary functional testing for all of the respiratory conditions. The reason why is because I think you guys will just be memorizing this without understanding it. Did you guys go over PFTs in detail with physiology?
No.
No. Okay. And so that's my concern, because that's like a whole nother lecture almost, okay, to go over PFTs. So what's going to happen is this. You will definitely go over it from a clinical aspect when you get into nursing, so I don't want you to think you'll be lost. But they'll go over exactly when you use PFTs, what you're looking for, and what the conditions are related to the different outcomes. So let's just X that out for right now. Okay. And so, do you have this chart? Okay, we're going to also X this out too. And the reason why, this goes over children and kind of like signs and symptoms and what happens with children with asthma. I have to do a whole separate lecture on pediatrics, so we'll save that for later. Okay. Now, diagnosis, ABG, something called arterial blood gas. So this is ABG, arterial blood gas assessment. And since we are talking about this, we are going to add this in for our clinical reference guide. So if you don't mind, if you can pull out your clinical reference guide. And I don't have mine with me, I'm not sure what page it's on. But there should be a section for arterial blood gas assessment. What page is that? The second page. 487. Thank you. Okay. 487. Page 487 in the clinical reference guide. So there should be a section for arterial blood gas assessment. So let me just explain this test really quickly, and then we'll go into the values. Has anyone ever had this performed or seen it performed before? Okay. Arterial blood gas assessment, for those of you who haven't seen it, I had it done. It's a very long needle, and it hurts like hell. Okay. And so what happens, you guys don't have to perform this, the respiratory therapists, they do this. But they have to go into the artery. It is a very deep puncture because artery is a little deeper. It's a deep puncture, and they do have to puncture in the artery to extract blood. And that's the best way to get a true gas assessment, okay, for situations like this. Now, we normally obviously don't have blood drawn from an artery. We have it drawn from a vein. But in this situation, in order to get a true assessment of oxygen content or gas content, oxygen really, they have to look at it from the artery. Okay, so now what we're going to do, if you can highlight, what do they have here? I'm sorry. Okay, yes. So let's do carbon dioxide. I would say highlight carbon dioxide partial pressure. You don't have to know the panic, okay, just the normal. So we're going to highlight carbon dioxide. We're also going to highlight oxygen. We're also going to highlight oxygen saturation and pH, which we should know. Okay, so keep in mind the pH of blood should be somewhere between 7.35 to 7.45, and we need that for optimal function. Okay. No, you don't have to know the panic, just the normal. And we don't have to worry about the sea levels. Okay, we can leave that alone for right now. Okay, so just those values, just add that into, okay, what we're going to study for next week's midterm. Okay, so we have a question.
Did you say the oxygen partial pressure too?
Yes, I think they have it listed. Yes, partial pressure, yes. Carbon dioxide, oxygen, saturation, and pH, thank you, and pH. Okay, so those four. You don't have to worry about sea levels. Now, when we have a person with asthma, when they have their arterial blood gas assessment done, what is a finding is this. They say during normal or mild attack, they will show some changes in the ABG. So let me make a correction here, because this should be respiratory acidosis, not alkalosis. Okay, so please make this correction. Cross out alkalosis, this should be acidosis. Now, why is this acidosis?
Increased CO2.
Very good, because carbon dioxide is elevated and oxygen is decreased. And we know from physiology that at any time you have increased carbon dioxide, that will lead to now leading into this acidic state. Okay, so this person is in a state of respiratory acidosis. Skin testing. Okay, so again, as I told you before, this is definitely another finding. I will put a star by this. I guess I would say this is another kind of hallmark, okay, because the other COPD conditions really don't have that allergic part to it. So skin testing is important. At some point, they should figure out what it is they're allergic to. Is it the smoke, the grass, the cats, or whatever, okay? Bronchial pulpitation testing. This is a test where they actually will use, I think they use like a nebulizer to administer histamine or methylcholine, which is another type of chemical mediator. And so basically, they're eliciting an asthma attack in a patient. I know it sounds mean, but the point here is that they want to trigger the asthma attack to see how the person's going to react, so they'll know how to treat it, okay? And so that's used for that. And then a CBC, you'll see elevated white blood cells, and again, the key thing here, the eosinophils. Treatment, avoid the triggers. So if they know what they're allergic to, stay away from it. Environmental control. We know that patients that have asthma, sometimes they have to get rid of the pet, they have to get rid of the carpets in the home, they have to make sure they have proper ventilation in the home. Even sometimes the air purifiers help, okay, because any type of dust or pet dander or whatever it is can trigger off that asthma. Preventative therapy, so sometimes patients are given, say, their bronchodilators, okay, nebulizers that they can use and just to kind of pre-treat at home, okay, if they know that they're going to be in an environment or go outside in the heat. And desensitization, allergen-specific immunotherapy. What do you think that means? In a nutshell, what do you think that is?
Exposing the patient little by little to the allergens.
Right, definitely. So these are allergy shots, basically. These are allergy shots. So we do know and have heard of individuals, and some of you maybe experienced this, that have to undergo allergy injections. Okay, and so when patients have allergy shots, it is used to, yes, hopefully desensitize, okay, the immune system from that agent. However, allergy shots is sometimes you win, sometimes you don't. Okay. Allergy shots, they do work in some individuals. Sometimes what happens is, those of you who know about allergy shots, people have to take a series for a long, long period of time to try to get the immune system desensitized from it. However, sometimes the immune system gets desensitized from the shot, and so that's where the reaction comes from, where sometimes they don't work. Okay, so that's that. Again, that's about children. You don't need to know that. Okay. Now for medication, let me put this on the board. Okay, so I just want to write down the treatment goal. Okay, so what's the goal of treatment? And we're going to go over all the treatments, but I just want to go over the goal of it. Is this. So number one, oxygen. Okay, so if they're lacking oxygen, that's probably one of the first things you want to take care of, okay, because they're lacking it. The next thing, whatever you need to do to open up the airway. And there's ways to do that, which we'll go over in a second. And then the very last thing is to decrease the immune response. Because remember, we said that inflammation is the culprit of this, so we want to try to decrease that. Okay, so oxygen therapy if they need it. Small volume nebulizers, okay, can be used with either oxygen or air, and that's to, again, just try to get them some oxygen and airflow. B2 agonists, those are what are the agents of what we call bronchodilators. So our B2 agonists are going to be our bronchodilators. And our bronchodilators are going to do just what it says. It's going to dilate the bronchi, okay, and open up that airway so they can get airflow. Corticosteroids, what they do, they actually relax the airway. So now these patients can also get flow. So it also opens up the airway. Corticosteroids, I think you know, are used very much so in asthmatic situations, as well as musculoskeletal type conditions. Because when patients do have musculoskeletal injuries or issues, steroids do help relax the muscle. So just think of relaxation, okay, opening up. And the very last thing, leukotriene modifiers and mast cell inhibitors. What do you think they're going to do?
Reduce that immune response.
Very good. Decrease the immune response. Okay, so leukotriene modifiers and mast cell inhibitors will decrease the immune response. Okay, so those are the treatments.
What exactly do the leukotriene modifiers do?
They're going to stop the
white blood cells?
The chemical mediators. So they kind of stop the chemical mediators. Mast cell inhibitors will stop the mast cell, and then the leukotriene modifiers will stop the other chemical mediators. Or I should say the chemical mediators. Excuse me. Here's a diagram that just kind of pulls everything together. Again, not going to have direct questions from this, but those of you who like diagrams, you can use it. And so let me do acute bronchitis, and then we'll take another break because chronic bronchitis and emphysema is long. So we need to spend some time on that. So even though acute bronchitis is not a COPD condition, they've kind of stuck it in here because it just kind of flows, okay, with the order of what we're going over. So acute bronchitis is just what it says. It's an acute bronchitis, inflammation of the bronchi. So this is an inflammation of the trachea in the bronchi. Most commonly caused by what? And some of you guys may know this already. Yes, you're most commonly caused by some sort of pre-existing condition like a common cold or flu. Okay, so what happens, we have a person that has a cold or flu, and the cough kind of lingers on a little too long, and then now they're continually having this cough that is now leading to this sort of infection down in the bronchi. Okay. And most of the times it is viral, which is, how do they treat this most of the times? Well, in particular,
There's really no treatment because it's viral.
there's no treatment, but how do they treat it? Because they treat it.
Antivirus?
Antibiotics. They don't use antivirals for this, they use antibiotics. Okay, so this is the issue. You guys will get caught up in this. Okay. Patients sometimes will have viral infections, especially when we talk about upper respiratory things. Okay, most of the times it's viral. It Can it be bacterial? Yes, but most cases are viral. What happens, the antibiotics gets handed out like candy. Why? It's kind of that placebo effect, okay, that we know. Patients go to the doctor, I'm sick, they're paying their $40 copay, I want something to make me feel better. Okay, seriously, this is what happens. And so what will happen is they're given the antibiotics, okay, for some viral conditions which are not supposed to be given out. You guys know what happens with overuse of antibiotics. Now, the physicians, the argument with this, especially for upper respiratory conditions, is that if you have a person that has an infection here, is it a possibility that it can lead to a bacterial infection and possibly lead to a pneumonia? Okay, this is what they're concerned about. And so this is their argument with why they give antibiotics, okay, to try to prevent that from occurring. However, most of these things are viral. And so the caution here is that if it is just viral, treat it as a viral. If it is just bacterial, treat it as a bacterial infection. Okay. And the other problem with this is they don't culture these all the time. Okay, those of you who work in the field know this. They don't culture this stuff all the time. Sometimes they culture it, but they usually just will give antibiotics without a culture, just based on signs and symptoms. Okay, so in any event, for the causes, I do want you to know that viral causes are usually one of the most common causes. However, they do have other causes that are non-viral. Okay, so these are some of the non-viral causes. And again, the non-viral causes are usually, again, what they're concerned about these patients leading into a pneumonia. Okay, which is what they don't want, which is why they say they give them an antibiotic. Okay. Other causes can be heat, smoke inhalation, and inhalation of chemical irritants and allergic reactions. So again, going back to one of the examples that I gave you, say a person that is working in a casino and they're working around smoke all the time or in a smoke shop, can they have it lead to a bronchitic situation? Yes, because if they're constantly inhaling smoke day in and day out, this will definitely cause an inflammation at some point. Okay, just like when I explained to you about when a person smokes a cigarette, when a person smokes, and this is the thing, no matter what you're smoking, whether it's a cigarette or something else, what's going to happen is you will definitely have inflammation, okay, that can occur. With nicotine or with the tobacco use, on top of that, that now includes the situation of possibly leading into now the carcinogens, okay, adding in the carcinogens. So, pathogenesis for acute bronchitis is pretty much the same as asthma. Okay, so the same kind of pathogenesis, they're going to have mucus secretion, all that. But two things I just want to point out. The last two sentences here, if you want to highlight, this is kind of their hallmark. These patients lose ciliary function. And they also lose portions of the ciliated epithelium. So which means we know cilia is there to sweep out and move the debris that's in the airway. So if they lose that ciliary function and it's stiff, that means that they have more of the mucus and everything trapped there, which is why these patients are always coughing. Okay, they're coughing because they can't get it out. Okay, so it's a constant irritation. And that's because of the loss of the ciliary function. So clinical manifestations here, cough, productive or non-productive, depending on if they can get it out. Low-grade fever, okay? And sometimes everything's not textbook, so just know that too. So I don't want you to think that each person's going to have each and everything. Sometimes they may have one symptom or the other, or maybe two or three. Chest discomfort, sore throat, post-nasal drip, and fatigue. So most of the signs and symptoms is a normal common cold. Now again, the concern, as I told you before, is it a pneumonia or is it an acute bronchitis? So with a chest x-ray, they can look at the lungs, and with a pneumonia, you will see what are called infiltrates, or areas where there's a lot of immune cell activity that has infiltrated the lung tissue. So understand that when you see the infiltration in the lung tissue, that's pneumonia. Bronchitis doesn't have that. Why? Because bronchitis stays just in the bronchi, just right in the bronchi and right in the trachea. But when it gets out into the lung, then that's the pneumonia. Okay, so that's the difference. Okay, treatment, if it is bacterial, antibiotics, okay, coughs, medicines, okay, cough syrups can help. Fluid, avoid the smoke and whatever's the irritant, and vaporizer. So some people don't want to hear that, but just go home and rest and drink some fluids. Okay, and that's it for acute bronchitis if it is bacterial. I'm sorry, if it's viral. If it's bacterial, then they'll give them antibiotics on top of everything else. Okay, let's take a break here because the other two are actually longer.
So, you won't get those 25.
I know it feels like a lot of lecture, but we have to move on to getting into chronic bronchitis and emphysema. Okay, and then we'll be done with this chapter. Okay, so chronic bronchitis, this is one of the most common that and emphysema of the COPD conditions. Okay, they do consider this in your book type B COPD, and emphysema is considered type A, and so A is the worst of the two. In your book, they use a term, blue bloater. That's not a clinical term. Call your patient that. But they just use that as a way just to help you associate with some of the signs and symptoms that they'll develop. So blue for the cyanosis that they'll have, so blue for the cyanosis of the skin. And bloating is going to be the weight. Okay, so these patients will look or appear as if they're bloated, but a lot of it has to do with tissue edema. So they do have tissue edema that makes them look larger. Okay, so blue bloaters. And so we'll get into that in a little more detail in a second. So chronic or recurrent productive cough over 3 months to 2 years. Okay, now that's a lot. Okay, so if anyone's coughing over 3 months, okay, something's going on. So that is a chronic cough. Now, this cough, or I should say this condition, is persistent and irreversible. I will highlight irreversible. And when we're talking about irreversible, this means on the cellular level. So irreversible cell damage that can occur with these individuals. They say these patients are usually overweight, around 30 to 40, over 30 to 40 years of age, and sometimes can be associated with emphysema, which again is the worst of the two. Okay, so we could lead into that. Now, the common cause of this is cigarette smoking. 90% cases are cigarette smoking. Please make sure you highlight that, and that is definitely the truth. We know that cigarette smoking can cause a number of things. One of them is definitely this, chronic bronchitis. Okay. Repeated airway infection. So as we talked about earlier, can a person that has an acute bronchitis lead into a chronic bronchitis? Yes. If that person continuously have those acute repeated airway infections, it could lead into a chronic situation. Genetic predisposition sometimes, and it also depends on the inhalation of irritants. But again, most of this is cigarette smoking. So what happens is almost, again, the same kind of pathogenesis as asthma, but with a few little differences. So they will have a chronic inflammation and swelling of the bronchial mucosa resulting in scarring. Please make sure you highlight scarring. Please understand that once we have scarring, that is irreversible. This is why we call this damage irreversible. Once the epithelium is scarred, there's no turning back. You can't reverse that. So the other things here, they're just going over the types of immune cells that are secreted. So we have interleukin 8 levels that will recruit neutrophils, CD8 T lymphocytes that will come around, and they all come and surround the alveoli. Okay, and so this is where the issue begins. If you have a bunch of immune cells pooling up in the alveoli, is this a good situation? No, because the alveoli is for what? Gas exchange. Okay, so just imagine if you have a whole bunch of immune cells filling up and taking space in the alveoli, that will definitely impair gas exchange, okay, from taking place. So this is an issue. And we would think, okay, well that may be okay for the moment, okay, to have, cells in the alveoli. That's not probably a big to-do for a little while. However, this is chronic. Okay, so this is occurring all the time, all the time. And the problem with these patients that some of you work in the field probably know, when patients have chronic bronchitis, do they stop smoking? No.
No.
Okay, unfortunately they do not. Okay, and so the problem is they continue this inflammation over and over and over again. Okay, so it keeps them in this state. Now, so which prevents the oxygenation and the airway obstruction. Okay, so they will also have a hyperplasia of mucus gland cells, just like asthma. So remember how we talked about with asthma, they have excess mucus secretion. Same thing here with chronic bronchitis. Okay, so they do have that mucus plug in the airway. And that's just a picture. This is a normal picture of a mucus gland. Not a big to do. So the other thing that occurs is this. They will have an increase of bronchial wall thickening, okay, which can lead to a whole bunch of issues. So it's a resistance of increase of work of breathing, meaning that these patients obviously are going to be working harder to breathe, okay, because of the obstruction, which increases the oxygen demands. Okay, so understand that the alveoli is all filled up, it's plugged up, it can't get the proper oxygen. They need oxygen, and on top of that, the airway is obstructive, so they really cannot get the breathing ventilation that they need, which means that they will have poor ventilation perfusion mismatch with hypoxemia and hypercapnia. Okay, so what does that mean? So ventilation perfusion mismatch, meaning that when we talk about the gas exchange that's supposed to occur across the alveolar membrane, that's not happening. And so it's not happening, or I should say it's happening improperly, which means that it will lead into a hypoxemia, decreased oxygen, and a hypercarpia, increased carbon dioxide. So hypercarpia, increased carbon dioxide. Now, it has here increased pulmonary artery resistance. What you should understand is this. If they're not having proper gas exchange taking place across the alveolar capillary membrane, do you think that that's a possible thing that's going to offset circulation? Yes, it can offset circulation. So understand that when this occurs, this sort of mismatch, this will offset circulation. So when it offsets circulation, this will actually cause pulmonary artery to increase in resistance. Meaning that the pulmonary artery, I'm going to draw it out, but I don't know how to draw it, what I'm saying. But the pulmonary artery will actually increase in its amount of pressure and resistance, which can lead to, believe it or not, pulmonary hypertension. Okay, so when you see increased pulmonary artery resistance, that is pretty much the first thing that leads to pulmonary hypertension, okay, on the physiological level. Okay, so this is a histology slide, and you don't have this picture on your picture pages, okay. I'm not going to test you on this, but this is just showing you the alveoli and how it's filled with all the immune cells and clogging up, okay, the alveoli. So here we go, pulmonary hypertension. Pulmonary hypertension, so just imagine pulmonary hypertension meaning that we have excess blood, pressurized blood, constricted vessel in the pulmonary circuit. Do you think this is going to affect the heart? Yes. And what side of the heart is going to be affected? If we're backing up in the pulmonary, the right side of the heart will be affected. So these patients could lead to right-sided heart failure. Okay, so just understand that pulmonary resistance leading to pulmonary hypertension. Pulmonary hypertension, backing up that blood in the right side can lead to right-sided heart failure. Okay, and then when we went over in 19, then you'll see signs and symptoms of the forward and backward effects. Okay, so the right-sided heart failure will happen with that. Now, clinical manifestations, SOB, not that SOB, shortness of breath. Okay, SOB for shortness of breath on exertion. Okay, And understand, when we talk about exertion, I don't want you to think these people are, running a marathon. This is just kind of like minimal exertion. Okay, so they're really, really shortness of breath. Excessive sputum, and the sputum and cough is more severe in the mornings. Why? Because it all kind of settles, okay, from overnight, and then when they get up, here we go. They have a whole bunch of sputum. And then evidence of excessive body fluids. Edema. They will have that edema. Why? Remember when we went over heart failure? Right-sided heart failure leads to edema, tissue edema. Okay, so that edema is associated with the right side of the heart failing. Okay, and cyanosis is a late finding. And usually with cyanosis, it's a very, very late finding because it's like almost to the point where the body is really, really depleted of oxygenated blood getting to the tissues. So how do you see or diagnose cyanosis on a patient? You guys probably know this. Blue lips and sometimes the fingertips. Okay, very good. Okay, so here we go. Here's a picture. And with this picture here, they're showing you the excessive body fluids, okay, with the edema. Okay, so this person is not just overweight. Well, they're also overweight. Patients that have chronic bronchitis, they say they're typically overweight. However, he also has a considerable amount of tissue edema, which is probably why they're showing the hand like that. Okay. Chronic cough, shortness of breath, and increased sputum. So on chest x-ray, if you ever look at a chest x-ray with this, you can see increased bronchiovascular markings. Okay, so what does that mean? When you look at a chest x-ray, there should be areas where you can tell where the vascular markings come from the bronchi, okay, in the lung field. And they should be in a certain field or range. If they're outside of that perimeter or larger, that's telling us that obviously there's more blood or it's in a state where it's larger. Okay, so you'll see increased markings in that area. Congested lung fields, and so you'll be able to see in the lung fields, okay, all of the inflammation. Enlarged cardiac silhouette. Why does a heart get enlarged? Keep in mind, blood is backing up into the right side of the heart. So the heart is actually going to appear larger, like a megaly. I'm sorry, say that.
With the pressure that.
So the pulmonary hypertension, the pressure of blood is high, which leads to a backup of blood in the right ventricles. And so it'll actually cause the heart to get larger because of the buildup of blood. And you can see infection, okay, in the lungs as well. Okay, pulmonary functional testing, as I told you before, you can X that out. ABGs, elevated carbon dioxide, as you would imagine, and decreased oxygen. Okay, so these patients will be, yes, in a state of respiratory acidosis. ECG. Now, you're probably wondering, they're doing an ECG. Yes, they are, because we already discovered that the right side of the heart is going to be an issue. Okay, so would you want to do an ECG? Yes. You want to see how bad or how much damage is occurring in the heart. Now, they have something called atrial arrhythmias. Okay, so when we talk about atrial arrhythmias, this is the issue. Blood in the right atria is trying to move forward to the right ventricle. Okay, however, blood is backing up. Okay, so blood is all in the right ventricle here, and it's just taking up space. And so when it's time for the atria to contract and push the blood in the atria forward, it cannot because the ventricles are filled already. So the rhythm of the heart is going to be off here, not here, okay? Because this kind of like quivers, okay? It can't have a full contraction because of that. So, and then again, as we said, they will have evidence of right ventricular hypertrophy because of the backup of blood in the right ventricles. Secondary polycythemia. And so this is something that can occur, kind of like a compensatory mechanism. Polycythemia is an increase in red blood cells. I don't think I gave you that term before, but polycythemia is an increase in red blood cells. Now, Why do you think the body's going to go into this state of increase in whole blood or red blood cells?
Because it's trying to compensate for the oxygen.
Very good. It's trying to compensate for the oxygen. Very good. This is a compensation. And this information that I'm going over is actually the same information that you're going to use to answer the questions for your signature assignment case study, which I'm going to have you guys do at home. I'll tell you about that afterwards. So this is the same information that you'll need to know. Okay. Treatment. Same treatment goal as asthma. Give them B2 agonists and other bronchodilators to open up the airway. Cough suppressants to calm down that cough because they do have a considerable amount of coughing. These patients with chronic bronchitis, they actually are more prone to getting bacterial and viral infections. So they say, like, when you look at the sputum or like when they explain when they're coughing up the mucus, they can explain the color. So like, what is it? The clear or yellow is more viral, whereas like green and more colors is bacterial. So they'll have more bacterial infections, okay, these patients. And then corticosteroids, okay, to also open up the airway. And theophylline products, from my understanding, is also another type of bronchodilator. Don't quote me on that from what I remember. But this can also be given to asthmatic patients as well. Okay, so it's another type of dilator. And low dose oxygen. So again, oxygen therapies can be given if they need. And management, don't forget, you can give them all the medications and everything, but they need management. Number one, tell them to stop smoking. Okay? And this is serious because most of the time these patients are the smokers. They're the chronic smokers. Bronchodilator therapy, so they can be given their bronchodilators at home, okay, to kind of pre-treat and things like that. Reduction in irritants, rest, hydration, and physical reconditioning. Why do they need that? They need it for their heart. Understand that cardiovascular function is not proper. So these patients need to physically recondition their bodies, okay, and it will help their cardiovascular function and pulmonary function. And so they need to also do that for management purposes. Okay, and so emphysema is our last one. And this is type A COPD. Pink puffers. I know. So pink puffers. So pink because the skin turns like a pinkish color. Puffer because of the type of breathing that these patients do. They do a pursed lip breathing. Okay, we're going to go over that in a second. So they do have a very distinct way that they breathe. So they say emphysema is actually diagnosed more commonly over 50. If a person develops emphysema when they're younger, it's usually because of the alpha antitrypsin around the alveoli that they don't have. So just to refresh your memory, if you went over this in physiology, alpha antitrypsin is what makes up surfactant. Okay, and we know we need surfactant for the alveoli, okay, to stay in their shape. So sometimes patients can be born with low alpha antitrypsin, and so now it makes the alveoli vulnerable. And so this can lead them to an emphysema. So that's more like the hereditary type, which is not that common, but more common is people that smoke and lead into this type of emphysema. Okay.
And what exactly is antitrypsin?
Alpha antitrypsin is the agent that makes up surfactant. So it's like, I don't want to say the enzyme. I forgot the exact molecule, but it's the component that makes up surfactant. So surfactant, if you remember, is kind of like that fluid that coats the alveoli. So the alveoli, so it increases the surface tension. And we need that, because if we didn't have it, then the alveoli will collapse. Okay. All right. So here's a picture. One lung, second lung, What do you notice the difference? This is obviously the abnormality.
Sponge-like.
Okay, it's very spongy-like. So if you look here to compare to here, this lung tissue is very porous. Okay, it has a lot of holes inside of it. It looks like a sponge. Now, normally when you guys looked at the lung and the anatomy with the piglets, okay, the lung tissue is, you know, not that spongy looking. It looks somewhat, but not to the point where there's a lot of holes in it. And so what you should understand is you see all those little holes. Unfortunately, each little hole probably represents like maybe 10,000 alveoli. Alveoli are really teeny, 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 tiny. So just imagine this is one cluster alveoli, that's another cluster alveoli, that's another cluster alveoli, and that one. So just imagine this person's entire lung having all those alveoli collapse. That person is really compromised, okay, of breathing. So that's the main issue with emphysema, is that once the alveoli collapse, that's it. There's no surgery, there's no medication, there's nothing you can do to bring the alveoli back, okay? So that's why emphysema is really bad. Now, what's the other situation here with this picture?
It's black.
It's black. Why do you think it's black? Smoking. I'm a cigarette smoker. Number one cause of emphysema, just like chronic bronchitis, is smoking. They have here over 70 packs a year. That may sound like a lot for people that are non-smokers, but for people that are smokers, that's not a lot. That's like a pack and a half a week or something like that. And we know that some people can smoke a pack a day. Okay, so that's not a lot. So what they're trying to say here is that over 70 packs is enough to start developing this type of damage. Okay, and we all know it's not each and every person, so every person that smokes doesn't lead to emphysema. However, the more long-term use, the more chronic use of cigarettes we know can lead to this. Okay. Air pollution can do it, some occupations, and again, that hereditary alpha antitrypsin. So, as I told you before, this is the hallmark. Please make sure you highlight this sentence where it says smoking causes alveolar damage. The smoking causes alveolar damage. Why? It does this. So, alveoli we know kind of look like grape clusters, and so you know that we do have that surfactant, okay, that coats the alveoli to keep it nice and tight. And so what happens is this: when a person has chronic cigarette smoking, okay, what can occur is that when the body undergoes that inflammation, okay, from the cigarette smoking, keep in mind that inflammation, yes, will be in the airway, but is it a possibility it can travel down the bronchi, travel down the bronchiole, and get all the way down into the alveoli? Yes. So when this inflammation gets all the way down into the alveoli, this is dangerous. Because when we have inflammatory changes that's occurring in the alveoli, what will happen is that it will now cause the body to strip away that surfactant. Once you start stripping away the surfactant, that alveoli is definitely going to collapse. Okay, and it's done. So that's the issue. Okay, and they explain this in this diagram. I don't know if you have this. Okay, so here's a diagram going over what I just said, so if you want to do that at home, you can. Okay, so the pathogenesis here, again, as I explained to you, enzymes from inflammatory cells lead to alveolar damage. It will damage the alveoli. Not only damage the alveoli, it will reduce the capillary bed. Do not forget, alveoli, what sits on top of it? Capillaries. Capillaries are the reason why we have gas exchange in the first place. Okay, so it's not just the alveoli alone. Remember, capillaries have to sit there. So once the alveoli is damaged, boom, the next thing that's going to be damaged is the alveoli because it's right there. So they will have a reduction of the alveolar capillary bed, which is what really leads them into not having that gas exchange. Okay. So this is a picture, you don't have this one either, so you don't have to worry. This is a picture of the alveoli, and they're just kind of showing you how it's torn apart. These patients also lose elastic tissue in the lung. Okay, and this is another thing that causes them not to be able to breathe. They have a decrease in size of smaller bronchioles, and the loss of radial traction is gone. So radial traction meaning, you know how we breathe in and out, okay, and we know that the chest wall moves back and forth? Well, understand that the bronchioles and everything else is doing that as well. Unfortunately, these patients, they lose that. So now the airway is just stuck open, which means that there's no pressure that exists with them trying to push air out. Has anyone ever seen anybody with emphysema before?
Yeah.
How do they breathe?
Because the shoulder cannot go up, down, and they breathe and talk.
And what is their posture?
Hunched over.
Like
Hunched over. And this is why they're hunched over, because they lost radial traction. So when they lose radial traction, they don't have that ability to push the air out. There's no pressure that's existing. So they have to just kind of lean over and try to force it out as best they can. Okay, so here's some pictures, okay, of normal person with emphysema, alveoli. Even though it looks kind of like blown out, you know, large, not that it blows up like a balloon, well, kind of, let's just say a balloon that bursts. But these are actually damaged alveoli, so they can't go back. Do you have 62?
Yes.
Let's cross out 62 and 63. We don't need to get into that. That is just going over the locations of emphysema, because sometimes it can just be located on certain parts of the bronchiole, and we don't need to get into that classification. It's not that important. Okay. So this we have to get into. Their signs and symptoms are very distinct, okay, and you'll know it when you see it. Progressive exertional dyspnea, okay, and again, the dyspnea gets worse over time, okay. I remember I used to work with a chiropractor that had emphysema. He smoked for many years, and unfortunately his case, he got a diagnosis of emphysema, then he got a diagnosis of esophageal cancer. He died, I want to say, a year and a half after that diagnosis, okay. And again, a lot of this was triggered from smoking. So his emphysema was so bad that he couldn't even walk from room to room to see his patients. And so it got to the point, and we're just talking about just a small little area. Okay, so the point I'm trying to make here is that the dyspnea really, really gets bad. Increased shortness of breath past 3 to 4 years. Then these patients will actually start to lose weight and get very thin. Can you imagine why? There's, I guess, kind of 2 reasons why. Why do you think these patients lose weight?
They lose their appetite.
Number one, they definitely lose their appetite. Okay, they definitely lose their appetite from everything that's going on, from the labored breathing, and it just throws everything off. What happens also with them not having enough oxygenated blood flow getting to cells and tissues, what do you think the body's going to do to try to get that energy? It's going to break down the fat. Okay, and so what will happen is they will definitely lose a lot of weight because the body is needing that energy. Okay, and what will happen, because the clinicians understand the physiology, sometimes they will put these patients on a high caloric diet, okay, because they know what's going on. Okay, they will also use accessory muscles, so respiration, to help them breathe. Pursed-lip breathing. This is what they do. So those of you who have seen patients with emphysema, they actually hunched over because they don't have that traction to push the air out, and they're Short breaths through the mouth. Now, if you're doing this all day, what do you think is going to happen?
Increase CO2 intake? Or,
You're going to not increase CO2.
oh,
You're going to do the opposite. You're going to increase oxygen. Why? Because what is this? Hyperventilating. That pursed-lip breathing, unfortunately, puts them in a hyperventilating type state. Okay? And so when you look at their ABGs, it's not going to be what you think. Okay? So they're getting the flow, okay, because of how they're breathing, their ventilation.
So would they still be considered respiratory acidosis or alkalosis?
Most likely it's going to be alkalosis when you look at it, because it's going to be flipped. However, with patients with emphysema, it can go back and forth. It depends, but the way your book explains it, because of the hyperventilation, they're going to be in an alkalosis. Okay, so here we go with the clinical manifestations. Some of these we already talked about: accessory muscles, okay, breathing, pursed lip breathing. Leaning forward, okay, I already explained that. That's a key thing too. Barrel chest, so kind of like that hyperinflated chest because they're not getting all the air out. And digital clubbing. I don't know did I show you a picture of that? No. Okay.
It's actually in the PowerPoint.
It's in the PowerPoint. Is it in this
The
one?
digit one, it shows the normal and the clubbing.
Where?
If you go farther down.
I think it's in the 23. Is it in 22?
22.
You guys don't have it. I'm just trying to find a picture of it. I have a picture. I was just gonna Google one and pull it up.
Right there.
Okay. So, what happens is this. Digital clubbing is where the finger pad gets thicker, okay, and wider. There's two philosophies behind this that I read. One, they believe, has to do with the lack of blood flow, okay, causing the patients to have this situation to the fingertips. And then another philosophy that I heard behind this has to do with the inflammation that's occurring. So the inflammation kind of makes more sense to me, because if you have a lack of oxygenated blood flow, to me, it shouldn't increase in thickness. It should decrease. It should be more like an atrophy. However, this is what happens. So you can assess this, okay, as they're showing you here by looking at the fingers. This is not always, again, with every patient that has emphysema. And then from my understanding, this is also seen in other respiratory conditions, not just emphysema, and also more common with patients that smoke. Okay, so sometimes people that have chronic smoking, they will have that sort of change, okay, to the fingertips. Okay, I just wanted to show you that picture really quick. Okay. All right, so some of this we already talked about. Yes, thin, barrel chest. Yes. Okay. Just two things I want to point out that are different. Lack of crackles. These patients do not have crackles when you listen to their lungs on auscultation. So when you do an assessment, you listen to their lungs. You don't hear crackles as much. Why? Because they really don't have that fluid from inflammation. It's inflammatory, but not to the point that it builds up a bunch of fluid in their lungs. Okay, it's more so an alveolar issue. The other thing here, decreased diaphragmatic excursion. So kind of what I talked about already. When you look at diaphragmatic excursion, it's sort of looking at, let's say if you're looking at a person's chest wall and they're breathing from A to P, should be moving back and forth. They actually don't have that, okay, or not as much. So their A to P diameter when they're breathing is decreased. Okay, it's not moving back and forth. PFTs, again, you don't have to worry about. Chest X-ray. I know I'm not an artist. That's all I can do. Okay. With chest x-ray, they will have evidence of hyperventilation, so you'll see that excess air. The diaphragm will be low and flat, okay, so showing you that the chest wall is bigger. Presence of blebs and bullae, so let me just go over that, which is why I drew this. We're going to talk about this hopefully in the next chapter. 23 with pneumothorax. So what happens is this: when a person has excess air in the lung field, okay, pulling it up, where do you think that air is going to go? It's actually going to start to form pockets. So these patients can start to form what are called blebs, which are like pockets of air that protrude out. Bullae, the pocket of air that pushes in the lung tissue. So that's what that is. Now, just to take this a little further, the blebs and bullae, these sort of air pockets, unfortunately they can burst. Understand this is excess air, it's all filling up and pushing out, okay? Just imagine like a balloon that keeps going. At some point it's gonna burst. And so when it bursts, what is gonna happen to that lung? That lung is gonna collapse. And so this is what leads these patients into a pneumothorax, okay? So sometimes patients that have emphysema can lead into a pneumothorax. The mediastinum gets narrow, even though I drew the heart kind of large here, but just imagine the heart will be smaller because the lung cavity, the air in the lungs will actually just push on it. ABGs, as I told you, because of the hyperventilation, they will have a mild increase in oxygen. I know it sounds strange, but because of their hyperventilating, they are able to get enough oxygen coming in because of that excessive panting. ECGs, I'm not going to have you memorize each and every one of these in details, but just obviously know that ECGs will definitely be abnormal because of what's going on with the heart. Yes?
So for oxygen therapy, I remember learning there's like a guide for COPD patients is 88 to 92 for O2 saturation.
Yes, so they do have a guideline that they look for with this, and I think it's in the next couple of slides. I'm not going to test you on that exact guideline because you'll get that in the clinical class, but they will look at the exact levels. So if the levels, from my understanding, drop below 55 or 60, then they give it to them. That's why I was saying before that sometimes it's up, sometimes it's not. Okay, so it just depends on the case of what's happening with that patient at that moment.
Is that due to the rebound effect that it can have?
Yeah.
The COPD?
So, well, because the person I knew that had emphysema, he actually he had oxygen therapy daily. So it just depends on the levels at that moment. Okay, so treatment, here we go. Oxygen therapy, as you said. They will also be given bronchodilators, cough suppressants, okay, corticosteroids. So they're treated pretty much the same as a patient that has chronic bronchitis. The problem here is that emphysema is actually a little more fatal, okay, because of the fact that they lose the alveoli and there's no way of turning back. And I think that's it. Is that the last one? Yeah. Okay. Oh, yes, thank you. I forgot all about it.
I'm totally
Forgot I
I think
was
it's on
recording.
the other side.
The silver, where is it? And I'm gonna write an outline for the midterm, and I'll have a separate midterm review where I'll just go through chapter by chapter, okay? Because I'm just looking at the time, and so let me at least just give you something to go by. Okay, so the midterm. Midterm will be 50 questions. Multiple choice. We will have some of those NCLEX style questions, just to give you a heads up about that. So we'll have those multiple, answer type questions. Not a whole lot, but just a few. And what else? In some questions, we will have some labs and pictures. Okay, so some labs and pics. So remember, you guys did highlight, okay, some of the labs from your laboratory sheet, and then the pictures that I gave you. Okay, so even the ones you have today. So let's go over the chapters. Chapters 1, 2, 4, 7, 10, which we know is just table 10-2, so we don't get confused. It's just that table, the handout that I gave you. 11, we went over in detail. 14, 15, 16, 18, 19, 20, 22, and 23. Do all that.
So we didn't go over 15.
We didn't go over 15?
That was the
That was the brochures, yeah. We went over it, but not in our PowerPoint way. Okay. So, what was I gonna say? Okay, these are the chapters. Now, what I'm going to do, I'm going to do a separate review video that will just kind of break down each chapter, just so you can kind of get a focus, okay, so what you should be paying attention to. Obviously, I always test you on the information, okay, that we go over in class, so that's that. Now, the take home is on 14, 15, 16, and 18. And so the take home is basically on most of the cardiovascular things that we went over. So that take home is actually kind of good, and I think it'll be like a good way for you to kind of practice as a self-test too, even though it's a graded test, but even just a self-test to get you prepared also for the midterm. Okay. So when you look at this information, just to kind of give you a little guideline, a lot of this is cardiovascular, yes.
Does the midterm focus on a lot of, most of the stuff we went over today, since we haven't been tested on it, or is it just
No, so that's what I'm going to go over now. So if you look at these chapters, a lot of this is cardiovascular, okay? 11 was also a biggie, okay, with leukemias. There was a lot of information with leukemias. So the respiratory, so the point I'm trying to make here is that I'm going to try to make the questions even as much as I can. However, cardiovascular is kind of split up into 4 chapters. Okay, so you may have a little more questions with that, and probably leukemias. Respiratory, like 22, that material was 70 slides, and there is a lot of information with that too, even though it's just like 4 conditions. But COPD conditions, it is a lot, so kind of go over. So you can tell the chapters that are like, have more material. That's obviously more material in the test as well. make sure you also go over the tables that I gave you, like within the chapters for those weeks. So like for chapter 7, I gave you 3 tables, which was tables 7-1, 7-2, and 7-6 with the markers. And we already know about table 10-2. For chapter 16, I went over hypertension. And so for that one, I want to say the blood pressure classification, which was table 16-2. That's another table.
What was the chapter 15? If you can recall.
Chapter 15, that one was going over blood flow disorders. So that was the one where we went over the information, but in the way we did it was with the brochures. So I didn't lecture on it, but we went over it as an activity.
Like the DVT.
So DVT,
Oh, those, okay.
varicose veins,
Okay,
aneurysms, so that information.
Okay.
And we did everything with the exception 23. I'm gonna have to do it as a separate lecture by myself. Okay. I think I can cram it in. And I think that's it.
These pictures are for chapter
Yes, those pictures are for chapter 23. So the pictures that you have today are for chapter 23. And the labs that we added in today were the blood gas assessment. Okay.
And there's no medical terms.
No medical terms. I didn't get no medical, yes.
Is the take-home test like what we've been taking in class, or is it formatted differently?
No, it's the same thing. It's on Blackboard. It's the same multiple choice.
Do we need a password?
No.
Those were
It's
for chapter
open.
16.
Yeah, don't, the title I couldn't change. So the title is, I couldn't change that. So the take-home test is just what it's supposed to be, 14, 15, 16, and 18.
Okay.
Yes.
I had a question about, do you curve anything in this class at all?
The only thing that we curve or round up, I should say, is the final grade. We only round up the final grade. But I don't curve, I can't curve, I should say, because of policy, unless it's like a situation where there was an issue with a test question or something like that, and I have to curve, but just not on a normal curve, just to do it. But we do round up the final grade. If it's like a 0.5 or higher, I can round up. So the final grade is always rounded up, so you can get the most out of your points. Excuse me, yes.
Since we're a week behind, what's going to happen to that one extra test we were supposed to take today?
Okay, I'm gonna be able to, we'll catch up, which means I probably have to give you another take-home test during the break.
Oh,
That sounds good.
it's okay.
Because that's the only way I will be able to do it. Okay.
Awesome.
So I'm just trying to get in what I can, okay?
You need to record this.
Because I don't want to,
Fine.
because I can't give a test week 8. I could push it to week 8, but I prefer not to do that because everyone's usually frazzled anyway during the presentations that day. So we don't want to do that. Okay. Yeah, the layout is honestly going to be the same as your weekly test. Nothing different. There's just going to be more questions. There's more material. It's a possibility. I have to do a minimum of 50, but because I'm looking at the material, I could probably push it up to 60 questions, maybe 55 or 60, but at least a minimum of 50 questions.
How many points is it?
How many points?
The midterm I think is, oh gosh, I can't remember. I think it's 100 points.
Can we
It's
do
150.
score right away, just like a
150.
previous test?
Okay, 150 points, yes.
Are we able to see our scores?
Yes, you can see it right away, just like how we take our normal test.
Okay.
Be prepared next week after the midterm, I still have to lecture, okay? So don't go home. We still have to lecture because I am behind. For those of you who like to pre-read, I'm sorry because I'm behind and it's kind of hard. The schedule's just way off now. But it is a big possibility next week that I will start reproductive system. and renal disorders. I think that's where I'm supposed to be at. And I'll possibly GI. It depends on how much I can get in that day. Yes.
How much time do we have to take the test?
Oh, you have plenty of time. You'll have at least an hour and a half, I want to say, for your midterm. So you'll have plenty of time. So it'll be the same again, the same layout. It'll be the same thing, so nothing different. The only thing is just more information. But because you guys have been tested on everything, with the exception of like what we just went over today, the respiratory and the cardiac is your take home, it should be, you guys should be okay. You should be okay.
Would it be safe to say that we focus more on the stuff that we've already been tested?
Yes and no. So sometimes people wonder, oh, you're going to put repeat questions. Sometimes I do put repeat questions, but I try not to put a lot of repeat questions. So I try to test you on things that you weren't tested on. So you want to study everything. Okay, so you want to try to study everything. Now, will you have repeat questions? Yes, because what happens, there is a question pool. So you will get some repeat questions thrown in there. But I don't want you to just kind of go back and study, you know, just that. So you don't miss anything. Okay. And I think that's it. Okay. Does anyone have any questions about the midterm? No, everyone's okay. Okay. I will have tutoring on Thursday if you start studying and you get stuck on something and you want to come for tutoring. I will have tutoring on Thursday from 1 p.m. to 3 p.m. in room 316.
314.
314, I'm sorry. I always get that room confused. 314, yes.
Will there be more questions on what we just covered today?
No, that's why I was saying I'm going to try to split it up. Okay, so again, I will have a separate video that's going to say midterm review, and then there's going to be another separate video for chapter 23. I'm going to be doing it by myself, not in class, so just to let you know, you'll see me in the room by myself. Yes.
When will that be uploaded?
This video is going to be up.
On chapter